Good afternoon, everybody. I see that we are nicely socially distanced, which is good and bad, and those are issues that we also will be talking about today. I would like to welcome you to this conference. It will be live streamed on LRT, so the audience is bigger than here. And later we will know how many people will be following us. It will also be later available on the websites of the university and of the Andrei Sakharov Research Center. I would like to give the floor for a opening welcome to the newly elected rector of the university, Professor Juozas Augutis.
Thank you very much. Ladies and gentlemen, representatives of diplomatic corps, colleagues and students, on behalf of Vytautas Magnus University, I would like to welcome you in this important conference on emotional well-being and social solidarity during COVID-19. As the rector of this university, I know in detail how the pandemic uprooted our daily lives and business. From a bustling multinational university, we almost overnight became asset empty, locked buildings, and isolated in our homes, and in need of finding a new form of interaction through electronic means. Our lives were truly uprooted, and during the first weeks we functioned in a hectic, slightly disorganized, and almost unreal world, trying to find new ways to live, interact, and maintain our emotional balance. Many of us went through a difficult time of adjustment, some more than others, and all their life has found a new structure, and COVID-19 has gradually become an integrated part of our lives. We still live in uncertain times, not knowing when the new normal can finally be replaced again with a real normal and all restrictions can be lifted. Or will restriction remain? And what if another pandemic will hit us? Are we ready for it? And will we be able to avoid a repetition of this rather traumatic collective experience? Of course, we should also look at the positive sides of unexpected and in a way undesired. For quite a few people, the pandemic has changed lives not only for the worse, but also for the better. And at least the climate benefited temporarily when certain sectors of economy came to then almost completely stopped. The skies above cities like Beijing or New Delhi had not been so clear for many decades. Yet, the pandemic has been warning us all, and if we believe science, which we do, there is a very good reason to believe that this is not the last pandemic we will have to deal with. So we need to study what happened, learn from it, prepare ourselves, and above all, try to keep our mental health and remain resilient. I am very pleased that this conference takes place at our university, which are pride in being in the forefront, investing in new generation and contributing to more healthy societies with citizens who are active participants in the global community. Once again, thank you very much for your being here. Thank you.
Thank you. So I would now like to switch to our second speaker at the opening, which is this always complicated technical issue. Shekhar? Shekhar, are you here? Let's see. I think Shekhar is still waiting. Just a minute. Shekhar? Yes. Okay, Shekhar. You need to unmute your microphone. So, Professor Shekhar Saxena is the Professor of Practice of Global Mental Health at the Department of Global Health and Population at the Harvard T School of Public Health. From 2010 to 2018, Professor Saxena was the Director of the Department of Mental Health and Substance Abuse at the World Health Organization in Geneva. In 2017, he received the prestigious Leonidą Award from Harvard Medical School. Professor Saxena. I cannot hear anything. Just a minute.
Hello, can you hear me?
Yes.
Okay, thank you very much, Robert, and thank you for inviting me to join this conference. Is it okay if I go on?
Yes.
I'm very pleased to join the third Leonidą Donskį Memorial Conference on the topic of emotional well-being and social solidarity during COVID-19. I'm sorry I'm not able to join you in the hall, but technology allows me to join, and I'm very pleased about that. This topic is very timely, as at least during my lifetime of about 40 years in the mental health area, I have not seen any threat that is as much as this during the last few months, which is to emotional well-being and mental health. This is as severe as one can experience any time. Mental health has always been one of the most neglected areas of health, but since the beginning of 2020, the needs have increased substantially and access to care has reduced very much. This has widened the care gap substantially, which was anyway very high. It was too high, too unethical to begin with, but now it is extremely high and cannot be tolerated at all by any civil rights-based organization. This has caused a lot of problems, suffering, disability, and other kinds of problems for a very large number of people. It was because of the high level of gap between what is available and what is needed that about 12 years back, WHO started its flagship program that was called MH-GAP, pointing out the need for reducing the gap. And it's also very appropriate that Mind the Gap is taken as a theme for the campaign by the Global Initiative on Psychiatry. We will hear more about it from Robert later on, but at this point of time, I wanted to say that COVID-19 is such an unprecedented threat to public mental health that we all need to work together to build back better. It was anyway, the system was quite broken, but we need to build it, and we need to build it better than what it was. What would that involve? To my mind, it will include increasing the priority given to public mental health as a subject within the health area, but also within the development area. It will also include investing in mental health much more than we have done in the past. Appropriately, the World Mental Health Day theme for this year, to be celebrated on 10th of October next month, is investing in mental health. And this investment has to be for financial resources, but also on human resources. Both of them are lacking at this point of time. This will involve also improving the quantity and the quality of mental health being provided to the vast number of people who need it. And this care has to respect the human rights of each one of us, of the people who are using the services, as well as their families. This will also involve a much larger involvement and contribution by the civil society, including by people who have the lived experience. And I'm very happy to note that Charlene Sumkal will be addressing this conference later, and she will have certain suggestions to make, which we all need to hear very carefully and to follow them. If this conference provides the thought leadership to some of these areas and charts out the way for future, this will be worth spending our time and our effort on this. I wish you all the best for the deliberations of this conference. I look forward to hearing much of what will be said and to contribute to the thought leadership, which I hope this conference is able to provide. Good luck with the scientific program, and hopefully it will make an impact, not only in the region that you belong to, but for the whole world. Thank you very much for your attention.
Just a minute. He doesn't hear me, so I need to write him that we thank him. Okay. Good. So now I would like to go back to the and move that one down. Okay, so what I would like to do is to give you an overview of this program that we started quite unexpectedly, almost you could say as unexpected as all the limitations and restrictions that were suddenly imposed on us because of the pandemic, which is the Mind the Gap program, campaign. So why Mind the Gap? The trigger to start this campaign was the fact that when I was reading the press and one after the other was talking about social distancing, having worked in the field of mental health for 40 years, I immediately realized that social distancing for a considerable number of people in society would have a double meaning, because they are already socially isolated because of their mental illness, because of their disability, and suddenly an extra layer is put on top of this. And so whereas for us maybe the term social distancing is not so important, for them this was like a hit with a hammer against their head. And so the initial goal of the campaign was to try to change this vocabulary, to change it towards physical distancing, because actually we're talking about physical distancing. And then at the same time, use the time to talk about social solidarity. Because at the time of stress, at the time of anxiety, what we need is other people around to help us cope with the stress that it entails. And so the origin is very simple. I asked a colleague of mine to think of a kind of slogan for the campaign, and within an hour he typed me back 3 words: Mind the Gap. And we know probably what Mind the Gap is. It's what is all the time told to you in the London Underground: make sure that you don't fall between the train and the platform. And it is very symbolic, because if we talk about Mind the Gap, it's the gap that is caused by isolation. It's the gap between how people without illness, without disability, see the effects of the lockdown, and people with mental illness and disability, how they experience these restrictions. And then it's the mind. It's the thing that we're all the time concerned about. And so As Shekhar Saxena mentioned, the pandemic has one very positive effect, and that is that very quickly, actually, within the first month and a half, more and more people started to realize that the pandemic was going to have a strong influence on mental health worldwide. And so it put mental health much higher on the agenda than we had been able to achieve hitherto. We have a special Facebook I will show you later, where all the time materials are being posted with regards to the interaction between mental health and COVID-19. And what we see is that there are groups in society which are really much more affected. If you look here on the left-hand downside, the number of infections within the prison system is far higher than in society. And if you combine it with the fact that the number of people with mental health problems in the prison system is much higher than in society, 4 times higher, you can imagine what kind of effect this has on life within the prison. So as I said, we developed a Facebook, COVID-19 and mental health. We developed a website, mental health and COVID-19. And then from there on, we started developing the campaign actually in a surprisingly quick manner. And one of the reasons is this lockdown. Because, I was one of the people who was, and Ineta probably remembers the meetings, that I was completely stressed out by the fact that I would not be able to get out of this country and fly. I had been flying around for the past 20 years, and suddenly I'm stuck in one place more than a week, more than 2 weeks. And for me, it was really difficult to cope with this. And then at a certain moment, I start to understand that actually sitting behind your computer and doing your work and having one Zoom after the other also resulted in a huge productivity. And because everybody was kind of locked down in their kind of living space or workspace, the responses were also much quicker. And so we were able to pull this campaign off the ground in a much quicker fashion than otherwise. And so it looked that we really hit the right button. Within 1 month, we had 50 organizations worldwide that supported the campaign, including international organizations like the World Psychiatric Association, like the Global Mental Health Peer Network, like the Movement for Global Mental Health. And so we really managed to get something going and to attract people to the message that we were trying to convey. We developed the visuals, the logo, and the banner in 40 languages. So here are a few of them. And, it turns out that that is not so easy. You think that, well, if you have the right font, then you're able to translate the Mind the Gap logo into Arabic or into Farsi or whatever. This is a matter of design. And it turned out that we tried to use the fonts within the computer, there would be words coming out that were totally different than the ones that we actually had in mind. There is one very funny situation with Arabic languages and Urdu and with Farsi. One of my contacts in the Netherlands is an expert in Arabic and internet, so he's developing fonts for Arabic languages. And so I asked him to do these languages, and he made them nicely in Arabic, and I put them on the Facebook. And then suddenly one woman wrote me that you have a big problem with the Arabic logo. I said, no, it cannot be, because it's a top Arabist who did this. Well, she said, you'd better check it again with him, because there is a big problem. And it turned out that in the slogan, it said, no to social distancing and social isolation, yes to sexual distancing and social solidarity. Right? So just one little word was put in differently. These are the banners, again, in 40 languages. Again, one of the problems was that to translate these banners in African languages turned out to be completely impossible. We wanted to have several of the South African languages, and eventually the solution was that instead of a slogan, we had a kind of mission statement in African, which was then translated into Xhosa, Zulu, Shona, Southern Soto, and in Afrikaans, where the banner actually also exists. Dozens of ambassadors, some of them top-ranking people, business persons, the lady up in the left-hand corner in the top, she has 300,000 followers on Instagram. So through these people, we managed to reach a much wider audience that we would have been able to do otherwise. And then with the university, we developed a Lithuanian campaign supported by various NGOs in Lithuania, of which representatives are sitting here on stage, with Vasaros Mental Health Hospital, with several other Lithuanian organizations related to mental health. And then eventually it was also supported by the Ministry of Foreign Affairs and with LRT, which is now live streaming our event. And I think this one is a particularly nice one when LRT decided not to use physical distancing again, to commit themselves to, not to use social distancing again, but to commit themselves to physical distancing and social solidarity. And this example is one that we are now using in other languages in order to convince media to follow the example of LRT. And we made a clip, which I want to play to you, to explain to a wider public what the campaign is about.
How are you today? These days, most of us feel vulnerable and unsafe. The changes that have occurred in the entire world were too sudden, and we still lack knowledge about the future. However, each of us knows people who find this time especially challenging. There are those who need care, are lonely, or have health issues. To them, social interaction is vitally important. Let's keep our distance physically, but stay close socially. Let's talk.
In Ukraine, our organizations, one of the sponsors of this organization, the Federation Global Initiative on Psychiatry, and also a Lithuanian-based organization participating in the Mind the Gap campaign, the mental health perspectives in Vilnius, have an ongoing project of 4 years working in the field of social care homes, which is this remnant of Soviet psychiatry, the so-called psychoneurological internats, where people are basically locked up for life because of chronic mental illness, mental disability, or just because they don't fit in society. In some cases, dumped by family in order to get them out of the way. And so with permission of the European Commission, we refocused the advocacy campaign towards the COVID-19 pandemic. Had a list again of partners in Ukraine that we're supporting. A whole list of ambassadors, most of them actors, actresses, and other people from the cultural field. And in addition, the European Commission in Ukraine provided us with financing, together with a couple of other donors, to buy personal protection equipment, which was a deficit in Ukraine. In particular in closed institutions, psychiatric hospitals, social care homes, and the penitentiary service. And so over the past months, we have been buying considerable amounts of PPE and been distributing to the various institutions in the country. From the Lithuanian Ministry of Foreign Affairs, we received 6,000 medical face masks, and we just purchased another 700 of these handheld infrared thermometers, which are now being distributed between the various psychiatric hospitals. And then we also are working on the same type of advocacy program, which is developing clips that will be shown on social media, but also by media outlets in Ukraine. And so within the concept of dealing with the effects of COVID-19, we are trying to introduce them into the subject of social care homes in Ukraine, where about 40,000 people are currently locked up for life. And so this is a subject which in society is hardly ever discussed. Many people don't even know that these exist, unless you have a relative there or you know someone who has a relative there. But now this is the chance of getting this on the agenda and convincing the government that something needs to be done and that these institutions need to be transformed. And so this is one of the clips that has been made.
в ізоляції, тому що вона залишається наодинці.
Это действительно сложно и жутко. Мысли ведь они никуда не ходят, они продолжают бегать. Обдумываешь, что происходит, что светит, что нет.
I will show the clip individually because I see that there is a problem with the, let me see, with the quality.
Людям з психічним захворюванням тяжко знаходитись в ізоляції, тому що вона залишається наодинці.
Это действительно сложно и жутко. Мысли ведь они никуда не ходят, они продолжают бегать. Обдумываешь, что происходит, что светит, что не светит в жизни. И, в принципе, изоляция вообще паршивая штука. Вообще ощущение отторжения коллективом – это жуть. Когда ты понимаешь, что ты в обществе неприемлем, что ты просто ошибся адресом, когда родился. Просто ощущение, что ты здесь неуместно. И сидишь в этом когнитивном мешке и не знаешь, куда тыснуться.
І тут, коли ти ізолюєшся, тому що ти потрапив до лікарні, ти ще і зверху ізолюєшся тим, що ти на карантині. Ти не можеш обійняти людину, яка до тебе приходить, привідати. Ти не можеш вийти елементарно самостійно на прогулянку.
Я думаю, что было бы здорово, если бы люди понимали, что на этой стороне тоже люди находятся. Не злобные монстры, которые просто вот у них цель сесть на шею и сидеть. А просто это такие же люди, и у них тоже переживания есть, у них тоже мысли есть.
Люди з психічним захворюванням потребують простого розуміння, простої підтримки, простого спілкування. Ми такі ж люди, як і ви.
So as you saw, the campaign in Ukraine is in 3 languages, Ukrainian, Crimean Tatar, and Russian. And in total, we will be developing 6 clips. At the end of the conference, I will show you the second, which has just been finished over the weekend. And then we went to South Africa. As you have seen, there were quite a few of the ambassadors actually from South Africa. Funny enough, thanks to the Dutch ambassador here in Lithuania, who was based in Cape Town and developed a wide network here and managed to involve most of her friends in South Africa in working with us. South Africa is going through a very difficult time. The pandemic got out of hand. It's the worst affected country in Africa. There is still the numbers are high. They have about 620,000 cases by now. But then they have the problem of the townships, and it's very hard to understand how many people in the townships actually got infected by COVID-19. And so the numbers might be much higher. Lockdown, very severe, is now opening up. But the country is going through a very difficult economic period. The last quarter, the economy was down by 50%, but also increased racial tensions. And the last that I was told was that even blacks are thinking of leaving South Africa because they only foresee a huge problem in the country. And so here we developed a campaign in 6 languages. So English, of course, Afrikaans, Shona, Southern Soto, Xhosa, and Zulu, which are the main language groups. As you might know, South Africa has 11 official languages. And the focus in the campaign is on two programs that are being run in the country. One is to provide families with people with disability or mental illness with food parcels, because for some very strange reason they have been cut out from the food parcel program. And the second is to have a virtual coffee shop for people with mental illness where they can meet and talk to each other in order to help break down the isolation. And so these are some of the ambassadors in South Africa. As you see, a lot of women, a lot of prominent business persons. One, Fazal Randera, a member of the, or ex-member of the Commission on Truth and Reconciliation that was led by Archbishop Desmond Tutu. And so we also are developing clips in South Africa. I will show you the first. They now have 8. And in total, they want to develop 12 clips. And again, have a campaign in social media, but also with regular media outlets. And the campaign is now officially supported by the Ministry of Social Affairs and will probably also be supported by the Ministry of Health. So I'm going to show you the clip, I think, directly in order to avoid the same problem.
How are you today?
Scared, lonely, and like I'm waiting for something horrible to happen. And I know I'm not the only one.
These days we find ourselves feeling vulnerable and unsafe. And we all know people who are finding these times especially challenging.
I know from my perspective of having a girlfriend who's been dealing with depression and anxiety, I think it's super important to listen and be kind whenever you can.
There are those who need care, are lonely, or have health issues. To them, social interaction is vitally important.
Take care of yourselves and be safe, please.
We need to encourage ourselves to explore the outdoors, revive our mind and souls in nature. Getting back to basics can leave one feeling invigorated and less stressed.
Be careful as well when you are out there in the world. Be respectful, wear your mask.
It's important, man, we're making eye contact even though we're not physically touching each other. The fact that we have to go out, we're making eye contact, we're smiling with our eyes. And that's one of the things that's been helping me get through this tough time.
Let's keep our distance physically, but stay close socially.
So let's raise awareness for mental health. Let's spread hope for mental health.
No to social distancing and social isolation. Yes to physical distancing and social solidarity. How are you today?
Scared.
Okay. So what are our plans now? By the way, so the names that you saw in the South African clip probably doesn't say anything to you, but these are the most prominent, musicians that every young person in South Africa knows. So we really try to incorporate people that are appealing to young people in order to pass on the message. So the next plans. India is now on the agenda. We have all the visuals translated in 7 of the languages. 6 of them you see over there. There is a group of Indian NGOs in mental health that have agreed to join the campaign. And as you know, India is now the second in the line of countries with the most cases. By now, I think it's 5.4 million. And so we will be working on the campaign over there. Again, India is one of the countries that now realizes that they have been underinvesting in mental health and that they really need to do something about this. And then we are working on the university platform, Mind the Gap platform, about which Ineta Dabasinskaya will be talking more later. And then at the same time, preparing for the next, because it is clear, probably to all of us, that this is not the last pandemic, that it caught us unaware, even though we have been warned for decades, actually, that this was coming in our direction. So a lot of the regulations that were imposed, some of them were successful, some of them were not, some of them could have been different. And so what is now important is to learn from the experience that we have now and prepare for a future one, in particular also for these vulnerable groups like people with mental illness or with disability. So we've been working with WHO and trying to understand the effect of the isolation on people with mental health issues in closed facilities. The Vila was on that committee. And now with the World Psychiatric Association, we're working on instructions for people working in the field of mental health, but for the next pandemic, not for the current one. And so this Mind the Gap campaign, which started actually, from very small, has turned into a big undertaking. Thank you very much. I then would like to give the floor to the next speaker, Dovile Jotkaite. She is a lawyer who graduated from the law faculty of Vilnius University in 1998. Since 2002, she is actively working in Lithuania and abroad, focusing on human rights and disability. She was involved in various international and national projects on human rights and disability, non-discrimination, mental health care, policy law, guardianship issues, and social inclusion of persons with disabilities. Dovile, the floor is yours.
Thank you so much. We were just looking to the program that it was some other plans for the program. Okay, but Your Excellency Ambassador, Rector, dear colleagues, and everyone who gathered here for such an important conference, and of course what Robert has presented already, the message and the issue about social well-being and social solidarity for everyone. I would like to speak, and I was asked to speak maybe more on the broader issue, on the people with disabilities and the effects that the COVID-19 restrictions raised, or the issues and challenges that the COVID restrictions raised on persons with disabilities in general. So when we speak about people with disabilities in general, we know that there are 100 million persons with disabilities living in Europe and 1 billion of persons with disabilities worldwide, and it is 15% of the whole population worldwide. So, but we also know that people with disabilities have been disproportionately impacted even previously, even before the COVID, because of the attitudinal, environmental, and institutional barriers they face. And this is not because of their disability, but because of the social, attitudinal, and other barriers in the society. And the COVID-19, unfortunately, it reproduced even much stronger those barriers that existed already, and the negative impact that people with disabilities faced on the day-to-day lives were both from the food insecurity, access to healthcare, testing, switching to the telework or life-death medical decisions, and to the social educational environment that people with disabilities live in. And the most serious complaints that were faced by the people with disabilities were related to the healthcare, including mental health, because we saw a lot of raising in mental health, emotional, psychological needs for people with disabilities and families who care for them, but also the accessibility to information and communication, because we very much faced also that the information and communication was not in any form of accessible to some people with disabilities, for instance, for people with intellectual disabilities or for those who have alternative communication needs. So the victims with disabilities of COVID were also those who were actually victims of neglect by the governments, neglect by the social, health, or educational systems. And as Robert has already very nicely said, stay at home and keep social distance. This was the main message introduced to all of us. But for some people, especially for people with disabilities or for elderly, this was even more clearer message or even imposed by the law. However, millions of persons with disabilities very much rely on professional assistance in their homes, which is impossible. Which actually requires physical contact with other persons, and it includes, for instance, carers, personal assistants, deaf-blind interpreters, and so on. So from one day to the next, persons with disabilities found themselves with no assistance, with no support from the authorities to those support services that they were having or receiving previously. So I gathered really a lot of reports, surveys, and recommendations from various European as well as international organizations, both the governmental one as well as non-governmental, and try to actually reveal the biggest impacts of COVID-19 to the rights of people with disabilities in this pandemic situation. So first of all, the right to health of persons with disabilities. Usually the pandemic also showed that there was a huge, first of all, underfunding of health care, especially mental health care system, as well as to the social system. And during the pandemic, there were much more inaccessible health information, environments, and also health services for people with disabilities, because all the planned or all the usual health services were again stopped or discontinued. And as well, there were several remarks or selective medical guidelines and protocols that were actually discriminating people with disabilities. And those were reports from, for instance, France, from Spain, from Romania, and as well as the Global International Disability Alliance. They referred to WHO, to all the other healthcare governments, healthcare facilities, and healthcare authorities to actually request that those protocols would not discriminate people with disabilities in deciding on access to life-saving treatments. The impact on the right of persons with disabilities to live in the community. This was extremely vulnerable situation for people with disabilities, because as in Lithuania, as well as in majority of other countries, a lot of social services, daily centers, daily social services were stopped, totally stopped, and people with disabilities just were left without any support at home. No support were provided for families, so actually families and the carers, they were left totally alone with 24/7 support for people with disabilities within the families. And in addition, psychosocial disabilities and people with, for instance, autistic or intellectual disabilities were also totally, the needs of those people were totally also not followed, because some of those people just cannot stay totally locked down, totally confined in their families at home, and need just to some space or some regime of being and having social interaction with others. Also, public information on COVID-19 measures were not systematically communicated and not disseminated in accessible formats. And this was also a very long story of Lithuania as well as other countries going for sign language interpretation, the obligatory sign language interpretation for each and every press conference, for each and every most important information on COVID from the Ministry of Health or other authorities. So easy read formats. I guess the COVID-19 was the situation that actually promoted easy read, because we all now see how to follow the hygiene of the hand washing of etc. That is communicated in very easy communication and easy alternative picture language, and this is what people with disabilities and usually people with intellectual disabilities read on their daily lives. So this actually has also promoted some easy read format of information communication. Of course, lack of employment or not having possibility for employment during the pandemic also led some people with disabilities, including families with disabilities, caring for people with disabilities, to the, again, even much worse situation, poverty, financial situation, and educational opportunities were also very much restricted. So some testimonies or evidences gathered from different reports state that people with disabilities were left at high risk without access to food, essential goods, and medicine, and prevented from carrying out basic daily activities such as bathing, cooking, or eating. And for instance, the France Disability Organization gave the message about the COVID-19 and disability, about the deteriorating of the living condition of many people and their relatives. Spain also reported documents of the most serious violations of human rights of people with disabilities. And also the even much worse situation on women who are taking care of people with disabilities within the families. Greece also declared about prolonged isolation of children with disabilities and their families with very disastrous results. Also in Lithuania, we also evidenced that there were no reasonable accommodation for persons with disabilities to purchase the food, and because shopping hours and the specific electronic shopping was also blocked by everyone who were purchasing the food during the first 2-3 weeks of the pandemic. So actually people with disabilities who usually are independent in purchasing those food from internet stores were not able to do so. Also, Netherlands, they did a survey on disability and COVID, which revealed that 60% of respondents who received professional support, actually this support was reduced, changed, or stopped. About 45% of respondents answered that physical health was deteriorating and the treatment were stopped temporarily or totally for almost 61% of respondents. Also, Netherlands cleared out that there were public transport protocols established with no access to public transport for people with disabilities, about the crisis and heavy burden on families with disabilities, with disabled children, etc. So the impact on the right to education of persons with disabilities was also very tremendous, because usually schools, all the schools, including special schools for children with disabilities, were stopped or closed totally, and education was provided usually through adopting remote learning practices, which again were not totally accessible for children with disabilities, and especially children with intellectual disabilities. So some families reported absence of required equipment, access to internet, accessible materials. All those were not actually available and possible for families raising children with disabilities. And in general, I would say that families with children with disabilities actually were left totally alone, without support, and parents were standing for all of the possible professional supporters, such as carers, social workers, special educators, therapists, etc. Of course, the impact of COVID on the rights of particular groups, and Robert has mentioned already persons within the prisons, and if we talk about prisoners with disabilities, it's again the totally unproportionately forgotten group: homeless people with disabilities, women and girls with disabilities that were at particular higher risk of violence, particularly if they were isolated or closed, and within the lockdown they were no visits allowed. So all those particular group of persons with disabilities also have been very much impacted by the COVID restrictions. And now I would like also to say some of the reports and results of the report that Robert has mentioned already, the impact of COVID on persons with disabilities living in institutions. And we know that from different countries there were different numbers of deaths, for instance, in care homes, in nursing homes, sometimes representing up to 50% of all COVID-19 deaths. So it was the WHO Regional Office of Europe Initiative Mental Health Program report published in July, which actually tried to identify and address the challenges for better response for the future in long-stay mental health institutions and the COVID-19 crisis, during the COVID-19 crisis. Survey conducted with 169 long-stay institutions in 23 countries within the European region actually assessed the impact of COVID-19 pandemic on services, staff, how protective equipment was available, how services and service users and residents with psychosocial and intellectual disabilities were treated during those pandemic times. There were 4 specific themes related to the crisis, and methodologically there were questions open, both open and closed questions sent out, and the questionnaire replies were received, and the survey results were presented in the report that I mentioned already. And the results on communication, infection prevention, control, delivery of care, and impact on staff and residents, quality of experience were discussed. Zoom speaking to us. And I just wanted to present some of the results, especially related to the care and treatment experiences. And one of the citation was there was no occupational therapy, psychiatrist consultations were discontinued, all education and rehabilitation services were discontinued. The COVID-19 outbreak has reduced the volume of mental health services or activities provided to the population to the minimum. And this was the answer of the administration of the institution, long-term institution, during this survey. And so the results were on the delivery of care, that care provision was affected by restrictions on activities, including closure of services and institutions, reduced human and physical resources, including staff and clinical input, limitations of the built environment, changes to procedures and routines, intrusive and or restrictive infection control policies and procedures. And discontinued services included both psychiatric consultations, education, rehabilitation services, day centers, employment opportunities. And if we speak about people living in those institutions for a long time, it was kind of total closure of any possible occupational things for people. They were just left alone in their rooms, both eating and staying in the rooms totally for the whole time of the lockdown. And just to conclude, that government responses were very different to the COVID-19, but majority or many governments, including EU institutions, the first their responses were totally forgetting people with disabilities when deciding on emergency measures and recovery plans, and only because very, very strong advocacy role and advocacy work of disability organizations, both European, international, national, all those recovery plans were tried actually to also foresee people with disabilities. So I just named a couple of European and international organization responses and recommendations that were raised. So it was Fundamental Rights Agency, Human Rights Watch, UN, WHO, all of those organizations were actually providing their reports, doing surveys, and providing recommendations how the emergency and how the crisis and response should be dealt, including and inclusive of all vulnerable people, including people with disabilities. COVID-19 will influence the whole social healthcare system, economy, but also hopefully it will balance the inequalities in EU, because now we have a very strong message for the EU funding for economic recovery to be inclusive and to respond also to the social and health systems and issues. And just to conclude that we also do have international obligation for people with disabilities. Convention on the Rights of Persons with Disabilities state that all necessary measures to ensure the protection and safety of persons with disabilities should be taken by the state parties, should be taken by all the governments in the situations of risk. So this was a very short kind of description of the effects of the COVID-19 on persons with disabilities, and it's now, again, up to all of us to advocate for the most inclusive responses of the governments for people with disabilities, not to be left aside and left behind in our society. Thank you.
Thank you very much, Dovile. I'm sure that we will get back to most of these issues during the discussion following the presentations. I would now then like to give the floor to Dainius Puras. Dainius Puras is Professor of Child Psychiatry and Public Mental Health at Vilnius University in Lithuania. Since 2018, he is Director of the Human Rights Monitoring Institute in Lithuania. He was President of the Lithuanian Psychiatric Association, Dean of the Medical Faculty of Vilnius University, and President of the Baltic Association for Rehabilitation. During the years 2007-2011, he was a member of the UN Committee on the Rights of the Child, and then from 2014-2020, he was the UN Special Rapporteur on the right to physical and mental health. Dainius.
Thank you, Robert. First of all, I would like to thank organizers and for this timely and needed important conference. And I would like to share my insights and reflections, both from previous position as UN Special Rapporteur, but also now working more regionally and nationally with regard to human rights and mental health, and in the context of COVID-19. So one issue is probably the most easy to agree, and this was reminded to us by Shekhar Saxena. Finally, mental health is out of shadows, everybody agrees, and then some disagreements start. The disagreements are about, so how shall we invest when we push states to invest more? Shall we invest in the same way, or shall we stop investing in the same way? Shall we change the mode of investments? Another way, shall we support status quo, or shall we abandon status quo? Or maybe we find some way, some golden middle way. Anyway, with COVID, this is exacerbated, and I will come back to COVID later. Global situation, but also regional, is that I think we all would agree that situation with human rights of persons who need and who use mental health service is unacceptable. I mean, human rights situation. Is this just because of lack of resources? I'm not sure, because the highest number of people closed in institution is in the richest region, which is Europe. So this helps us to think creatively, not that just more money will solve the issue. All stakeholders should rethink their position on important issues and their role. Global movement for mental health, and I should add WHO, should critically or more critically address status quo and not undermine human rights-based approach. Mental health promotion, as we know, is about everyone, and all forms of inequalities, discrimination, and violence have negative impact to mental health. I think we all agree on this, especially in democracies. States, this is why I need to invest in enabling non-discriminatory and non-violent environments in all settings: family, school, workplace, community, healthcare services, mental health care services, society at large. Of course, the role of civil society is crucial, and we witness globally, but also in this region, also in Lithuania, attacks on human rights in general, attacks on universal human rights principle. So how can we expect improving mental health with all these ideologies like traditional family values, which are against rights of women, rights of children? So this is about broader picture, that mental health is not only about mental health services. The mandate which I had for last six years has interesting interpretation, normative framework. I mention only now freedoms and entitlements. This creates this situation of tension or impasse about mental health and human rights, because entitlements is that each person who needs treatment, let's say, should have it, and some psychiatrists will add, if not voluntary, then involuntary. But on the other side, all people should be free from violence and coercion. So we see very clear tension here between the role of psychiatry and human rights-based approach, but this tension is meaningful. So participation principle is very important, non-discrimination, accountability, international cooperation. And we need to learn a lot. We should not forget history, because there were many attempts to make people happier, to make all people healthy, to fix all disorders, forgetting to ask people if they want this to be done. We know stories with lobotomy. One of most interesting events was when I attended World Congress of People Who Hear Voices, And then they convinced me, and I was then conveying a message to elite of psychiatry that we should stop discriminating these people disproportionately, because they suffer gravely from this kind of medical education, that if your patient hears voices, you should go to involuntary measures immediately. So you have to hospitalize, and a large portion of population lives with voices, and they should not necessarily be treated by force. Just one example. CRPD, Dovilė mentioned, now 14 years. Basically, psychiatry is ignoring CRPD, and this is interesting issue which should be somehow addressed. Central Eastern Europe, our region. All regions are somewhat different. This region has this legacy, that huge number of institutional care, even more excessive medicalization to compare with other regions, because we never had, for good or for bad, we never had psychodynamic era. So it was always brutal biomedical model, just coming from the East, now coming from the West, and psychosocial interventions still not reimbursed in good way. So widely spread human rights violations persist and even are reinforced with substantial financial support from EU funds. Institutional care homes have been renovated, so you cannot close them. It's a holy thing to be renovated by EU funds. So the question is, what message do middle and low-income countries receive from high-income countries? How mental health services will be developed in Africa or Asia? Or what Lithuania can teach Ukraine? Success or a story of success, or maybe story of failure of reforming mental health services. Messages from Geneva. Geneva, as you know, is UN human rights capital, and I had a lot of experience to work with Human Rights Council, which otherwise is not necessarily human rights friendly, can be very human rights unfriendly. Interestingly, in Human Rights Council is extremely modern and progressive. There are 3 resolutions by UN Human Rights Council which urge states to move away from institutionalization, over-medicalization, coercion, and so on. My reports added to this, and I question the idea of global burden of diseases. I think it adds to unnecessary over-medicalization and discrimination of people who have mental health conditions. And instead, I recommended to address 3 obstacles to realization of mental health. This is excessive dominance of biomedical model, which did not keep to its promise to solve the issues. Overuse of biomedical interventions, huge power asymmetries. So psychiatry is the only field which ignores the principle of informed consent. And biased use of knowledge and evidence, so that medical students learn from textbooks that depression is about chemical imbalance, which is a hypothesis which was never proved. So key recommendations and messages from reports. I should especially highlight, moving to COVID situation, that one of recommendations, they were global, because my mandate was global, so I could not focus on this region. For example, I have to see global picture. So stop directing investments to institutional care and redirect it to community-based services, especially in the context of COVID. We know that institutional care homes are hotspots for infection, but also critically address excessive medicalization of common mental health conditions, especially with COVID, when many people become anxious or sad. I will come back to this. And then recommendations were for states. I should mention one of them: develop a roadmap to radically reduce coercive medical practices with a view to their elimination. The idea is that there's a lot of tension, between CRPD committee and, let's say, WHO or progressive psychiatrists about whether to ban non-consensual measures. So my position is that if we don't ban, if states don't ban, so at least they should move towards reduction of coercion. In Lithuania, for example, the law was passed 2 years ago, which expanded possibilities to use coercion, to use involuntary measures. So it was against all international recommendations. Urgent need for the shift of paradigm. This is or people or organizations or experts which disagree with status quo, who say that status quo is unacceptable. So, and I joined this group, is about human rights imperative, that we should not use these exceptions because they turn into the rule. If we allow exception in mental health care, and if we tell that, okay, psychiatrist has a right to deprive a person of human rights, so then this exception, especially with countries with problems with democracy, will turn into the rule. To prevent medicalization of human diversity, misery, and mental health conditions, mild mental health conditions, prioritize culturally appropriate psychosocial interventions, replicate good practices, exchange good practices. We know in Finland, for example, they are proud, and I am proud that Finland has this open dialogue. Not in Finland, no, but Finland was, in Finland, open dialogue was born. It shows that it is possible to manage in non-coercive way even most complicated cases if we really decide that we want to abandon culture of force used against people with psychosocial disabilities. Issues for debate today or later, two of them are eternal, maybe for psychiatry, is the argument of applying non-consensual measures because of dangerousness strong enough? We have a lot of arguments that this is not evidence-based, that you cannot manage dangerousness with psychiatric measures. And another is medical necessity. Is this argument strong enough scientifically that you can use coercion for involuntary treatment? But if the other side tells that you give treatment with force, with violence, it will never work in the long run, for example. So there is a very interesting question: what could be a new role and mission of psychiatry in the new paradigm of post-CRPD, of post-COVID-19, and if there are more and more right-compliant mental health services. So now COVID-19, my reflection is that with COVID-19 we have even more arguments that something very wrong happened with status quo, and such crisis like this is a good opportunity to make essential changes, not only cosmetic changes. For example, numbers of children and adults, we all agree, with elevated anxiety and sadness now are on the rise. And we have, every day we read publications, like yesterday I read that from US that depression, prevalence of depression increased 3 times. So what does it mean? Shall we medicalize all this? Shall we qualify all this as mental illness? Shall we agree that tsunami of mental diseases is coming? I disagree with this concept. This is normal reaction to not normal situations. So if all these cases will be medicalized, if again somebody will tell go to doctor and doctor will prescribe pills because you are depressed, I think it will lead to even more problem with the system. Other issues about segregated residential institutions and psychiatric hospitals, they easily may become hotspots for virus. So shall we continue to invest in legacy of such institutions? So I think this is good time to convince governments and to move towards their closure. I don't tell that let's close today or tomorrow, but let's decide when are we moving towards closure, or we are playing the game we were playing for 30 years. When in the end we renovated all these institutions, and now we even do not think about closing them. So, and this brings again this like case of Lithuania, which because we're here, many good examples with many fields, including healthcare. But I am not convinced that Lithuania was successful with the reform, because we do not have a real community-based services. The so-called primary mental health care centers they do not provide community-based services, because they even do not know that they should stop institutionalization. Nobody never told this to them. So there are waiting lists, and outpatient psychiatrist is telling to relatives, you just have to wait, and then sooner or later you will have possibility to bring your relative to this institution forever. So this means that the system is not working. And this is one of examples of status quo enforcing over-medicalization, institutionalization, disempowerment, and exclusion. So I'm not sure if this example can be recommended to more Eastern countries, because in that case, I don't know, Ukraine maybe after 30 years will have, Robert, you told 40,000, so they will live in better, these buildings will be renovated. So I do not recommend such kind of reform. So, and to conclude, there are interesting parallels between all public health crises, because we have pandemic of COVID-19, and we have so-called epidemic of poor mental health. And both these crises teach us or remind us that there is no hierarchy of rights. Indivisibility of all rights is crucial. Selective approach to human rights and human rights abuses in the name of medicine and in the name of saving life. Escalation, this panic, you know. It happens with psychiatry, that if you don't close some people, they can kill everyone. And it happens with COVID, yes. We can overreact, which is popular to do. So, and there is a lot of evidence that this, in the long run, this does more harm. The repressive psychiatry, when psychiatry is used for social control, and maybe with COVID-19, in the beginning of this epidemic, I still was a special rapporteur. There was a lot of pressure from many countries to disconnect right to health from other human rights, and to create this alarming situation that all human rights now need to put on moratorium because people are dying. And this is very dangerous. So it's a test to democracy. So all healthcare services, including mental health services, should be free from discrimination. We learned a lot from AIDS story, yes, how people were not friendly to key populations. People who use drugs, sex workers, men who have sex with men. Finally, even dictators, even non-democratic leaders realize that it's not funny. If we want to defeat these epidemics, we need to apply human rights-based approach. So I hope that we will be more persistent in applying fully, not selectively, human rights-based approach in mental health services. And COVID-19 pandemic offers a unique opportunity for mental health policies and services to abandon outdated practices and to fully embrace human rights-based approach. So thank you.
Thank you very much, Denius. I'm sure that we will also come back to some of the issues that you have in your presentation. So I would like to go to the third Lithuanian presentation today, which is Robertas Pulvilaitis. Robertas studied psychology at Vilnius University, graduated in 2000, has a PhD in psychology. From 1997 onwards, he worked at the Child Development Center in Vilnius and is currently director of the NGO Childline and lecturer at Vilnius University. He was president of the Lithuanian Psychological Association and also Secretary General of the European Federation of Psychologists Associations. Robertas.
Yeah, Your Excellency, Ambassador, the organizers, their colleagues, their participants, I would like to share the experience that we have in Childline, in the helpline for children, what happened during this year when the pandemic arrived to us. Sometimes people ask us, do we receive more calls to the helpline? And so I would raise the question, is the number of calls an indicator for the prevalence of problems? And here is the data from this year, starting from January until August. What happened with the number of calls? So we have two lines. The line above is the number of attempted calls, and the line below is the numbers of calls that we answered. So you see what happened. There was a decrease which started in March, and there was the lowest numbers of calls attempted and answered in April. And then gradually it started going up a little more, and now we have almost a similar level of calls that were coming in January. So what we see that there were much less calls during these highest restrictions time. And does it mean that children were worried less? Yeah, probably. I don't know the answer. I just could share only my ideas and reflections about that. I would say that it's not the case. It doesn't show the prevalence of problems among children. Because if we look into what happened on the internet and on the chat service we saw the opposite direction. There was an increasing need for the support, and there were more children willing to talk to us on the internet. So we had even to open more lines and more hours for chat service. So we see that probably the internet support was and still is the service that you can use it more privately, because if you are living at home with parents and you are spend 24 hours a day in that environment, and if you have some difficulty, and if that difficulty is connected to your parents, so how can you talk openly on the phone? So maybe this reduction of calls reflected the change in the environment that where children were living. Let's see what happened with the different worries that children were calling us to talk about. So now I will show you some numbers, and these numbers reflect the percentage of themes or those themes that children were calling. So this will be percentage of those calls where we identified some difficulty. Let's say there were, 100% of different difficulties, and now those numbers will show the percentage of that, of 100%. Physical health. So all world became sensitized to the physical health, to the virus. And what we see from the calls, that the number of children that were calling to the helpline to speak about different physical health issues and worries of their health, of health of their relatives. So this percentage was started going up, and it you see it went up, and it stays there until now. Again, these are not huge differences, but anyway, it was in the beginning of the year a little more, let's say 6-7% of all calls with difficulties were related to physical health, and now during last months we have around 10-11%. So that is about physical health. Now, what concerns schools and school difficulties. So what we see that, well, the numbers here are not very big, 2-3%, let's say in the beginning of the year. In the March, when schools were closed, school learning difficulties dropped down. And then when in April they were opened, numbers jumped a little higher. And then when we came to the summer, all these difficulties almost, or let's say these worries from children almost disappeared. Homework, a similar pattern. There was very seldom calls about difficulties about homework. And in April, when schools opened, again, reopened, let's say reopened distantly, yeah, with classes and learning through the internet. So the number again jumped a little bit higher, and then it went to very low numbers in summer. And now I will mention anxiety and sadness, and Dainius Pūras just was reflecting on these issues. Anxiety, what we see from the calls to the helpline. We see that, there was anxiety is one of the themes that is always there, that children are worried about something all the time, those who are calling us. So it was around 6-7%. And when the pandemic started, this number started growing, and a little bit by several percents, and then it stays again. It fluctuates a little bit, but it's a little bit in a heightened level than it was before. And if we look into the sadness, what we see again very clear pattern that with the pandemic it started going up. And then when these restrictions went down and the summer came, again, the percentage became the same as it was in the beginning of the year. So in other words, you cannot be sad all the time. So you are sad for a certain time, and then you come to your usual state. This is about leisure activities. Some children are call us and discuss with us that they have let's say, don't know what to do in the free time, and it's for them they're willing to find some activity, and we see that with this pandemic again. We go to the March, April. This theme was became more frequent, and then it stays there during the summer. It seems that there are again for children the question is what to do in these times. In summer, when there is no organized activity like school, what school provides for them. And the next point I would like to mention is again these reflections that I'm sharing. So I'm judging that and making these kind of conclusions from those children that are calling us, but many children are not calling us. They are talking to their parents, they're talking to their friends, and but from those calls that we receive, it might be that, let's say, for some children, if they had problems before this pandemic, so during the pandemic and especially during those quarantine times, some problems could become bigger problems. And here I could show you the two slides. One is about children who are calling and speaking about self-harming themselves. So there is a percentage all the time, a certain number of children are calling, but during March and April, we see the peak. So again, these numbers are not numbers of children, but these are percentages of how many what percentage of children that called us spoke about self-harm. So we see that more children were speaking about self-harm than before the pandemic, and if we compare now with the last months in summer. And the other indicator, it could be about calls where children have suicidal thoughts. We see a similar pattern that, in March and especially in April, there was a peak, there was, I would say, serious increase of, again, the theme of where there were suicidal thoughts expressed. So these type of calls were much more frequent than earlier. Of course, earlier, if we speak about 10% of those calls with difficulties, so that's already much. But 15 is, I would say, 15% is a serious increase. Again, it went a little down and stays at around 10%. So with these, this difficult time of pandemic, it seems, well, it could be that for some children, for children that had a supportive family, maybe that for them, this time where you can spend more time with your parents, maybe it was not a very big problem. But if you had some difficulties, if you had difficulties with parents, if you had difficulties with peers in schools and so on, so this time of restrictions and being in the same environment with parents with whom you have problems might worsen the situation. Several other comments about the relationship with peers and parents. I would say that all the time the dominating theme when children call to the helpline is relationship with peers, except this year. So usually if we look into the whole year, the year before the last year, so always it's relationship with peers. And this year, you see what started happening in March and in April and in May, that the dominating theme, it switched with, so relationship with parents became more frequent than relationship with peers. Again, these differences are not huge, but this is what happened. So again, if you are spending all the time with your parents in a family, so things might become difficult sometimes. And the other issue is about parental alcohol problems. So there were different discussions, reflections about that. I do not have the numbers of alcohol consumption in reality. This is, I don't know. But I see from children calls that the worries from children grew up. I mean, there were this theme that children became worried about parents misusing alcohol, became higher, and then again it dropped in the later months. Well, again, I don't know how it's if it's reflected related to the actual consumption of alcohol, but this is what children report to us. And again, if all places where parents were using alcohol, let's say pub, restaurants, bars, and so on, were closed, so they were doing that probably in the environment where, in the family environment, and probably children started seeing more of their parents consuming alcohol. Does it mean that adults started using more alcohol? This is what I don't know. But children started seeing or worrying about this. And about physical abuse. Also, there were different questions. Does violence at home increase during this pandemic or during the quarantine time? So what we see that in April there was a reduction of that theme. There was less children among other themes. This theme became less frequent, but it grew a little bit in later months, and again it went down, and it's so I don't know why is that, and then we need to look into the official data, but it can be that when you maybe sometimes problems might manifest after some time. So it's like you are sitting in the quarantine and things are the temperature is growing, and at some point it might become some problem, but not necessarily the same month, or it might be some time after. And now coming to the closer to the end, I will mention the problem of bullying. So what we see here, that bullying was one of the most frequent themes when children were calling to the helpline, and that was for many years one of the dominating themes. And what we see, what happened, it started dropping in March, it went seriously down in April, and it goes a little bit up during last months, but it didn't reach the level that was in the beginning of the year. So, and when I'm looking, let's say, exploring the issue of bullying for many years, and I never found a statement where it was written that the best method to stop bullying in schools is to close schools. Because this is what it seems happened, that schools were closed. The environment where the bullying was manifesting was not available to exercise this form of aggression. And when all learning process moved to the online platforms, I think that children were not used to those platforms yet to learn how to exercise this aggression. Teachers were not used to that environment as well. So those couple of months were like just to understand what is happening here and how we communicate to each other. And so you see that the numbers of this team didn't went to the level we had. And from the two last slides are from the survey that we did when we asked teachers who were working with children, could they compare what instances or how many instances of degrading treatment between children they saw before the quarantine and after or let's say during, before quarantine and during. And if we see on the left, we see those three biggest numbers. These are for different age groups, for preschoolers, for 5th to 8th grades, and for the 9th to 12th grade pupils. So we see that teachers noticed, many more teachers noticed degrading treatment before the quarantine, when the usual school time was school life was taking place, and during the quarantine there were they observed much less cases of degrading treatment. And I use here degrading treatment instead of bullying, because sometimes, well, bullying is by definition thing that is repeating several times, but we thought let's look into more broader form of behavior. So it's degrading treatment, so it doesn't need to repeat. So if it happens at least once, that is already the thing that we wouldn't like. So the teachers saw much less degrading treatment during quarantine. And when we asked those teachers about students' report, I mean, when students say something to teachers that, look, something happened bad to me, that other pupils are humiliating me, so the same pattern that most of teachers say that the students were reporting much more often before the quarantine in comparison to the time when this quarantine took place. So this is what I wanted to share with you from the experience of the helpline about children mental health. Thank you very much.
Thank you very much, Robertus. We are now going for a coffee break, which is downstairs in the cafeteria. Please use a mask and keep the appropriate level of distance. On the way out, you can take the transcript of the previous Donskis conference, which took place last year, Thoughts about the Other Russia. And I think there are no cookies at coffee break for restriction reasons, right? Okay. See you here at 3:15. Thank you. Oh, okay. So what happened is that Shekhar couldn't hear me, and I don't understand why. We tried, but so I'm not here.
Where's this computer picking up its sound from?
Yeah, that's it. That's the. So let me see where is the microphone. Zoom meeting is using your microphone. Because if this should work. You see, I don't understand. He couldn't hear me. I don't.
Hi, you recognize me with mask? That's
yes,
great.
yes. Good to see you.
Okay, congratulations. You managed it pretty well, except for this little mishap here.
I hate this technical
But how surprising are those numbers. April was the worst month for all, but not for these purposes.
Yeah, it's very interesting. We still don't fully understand how it worked out.
Yeah, I would expect much more violence inside.
But you know, in the family, the first weeks it's still kind of you manage, but then a couple of weeks it just goes crazy. But domestic violence was up, like in France, 30%.
Right. Yeah. And I mean, if you are, let's say, abusing parents, you avoid your son to call or your daughter to call. Because you can control everything.
The point is also that you have the opportunity to call. And when you're all the time in a closed environment, you don't have the...
Okay, I don't want to.
I'm actually going to have to slip out at this point. So thank you very much.
And this I want to give you. This is some of the reports that I mentioned. This is all about social care homes and stuff like that in Ukraine.
Lovely. Thank you. Thank you very much. And yeah, I've been in touch with Michael.
And
it's the
that,
same.
yeah?
Yeah, yeah. Oh, yeah.
Ah, okay. Yeah, you can't miss him.
Yeah, and also he's barely aged in 20 years.
I thought he was much younger.
Well, he's 3 years younger than me, maybe.
Okay. Yeah, but he looks like, you know, like, I don't know, 30?
He must have a painting in his attic or something. Anyway, this has actually been really interesting. Thank you very much. Sorry, I can't.
You're very welcome.
Wish you the best for the rest of the
Thank you. Bye-bye.
Thank you. You mentioned this Sahara conference next year.
Yeah.
So what is the usual thing we have done? A speaker?
Yeah, speakers, and sometimes, like in the previous conference, the farewell reception was at the...
and it's going to be here? Or
it's going to be in Vilnius. In Vilnius.
Vilnius.
In Vilnius.
Okay.
Yeah. So the opening is at the Seimas, and then we will move to the Old City Hall and be there for 2 days.
Okay.
So what I can do is, if you would have time, I could come over and also explain what we're doing with Belarus.
Yeah. In about a couple of weeks of time.
Yeah. There is no rush.
My secretary has been very, very effective.
There is no rush. Belarus will be around for a long time.
Yes, that's why I have to go back to the office because now we are heading for the European Council meeting.
Okay.
And a couple of things have to be clarified.
Okay. Oh, but somewhere second half of October.
Yes,
you know.
that would be great.
And then I can also we can discuss what would be the possibilities.
Yeah, but we need to have the yearly planning, so I'll put it in way that we will get you a speaker there.
And actually, this conference was supposed to be a different conference, which is now next year.
Okay.
Which is on the role of museums and public space in remembering the past.
Okay.
So we will have that one, but a year later.
Okay. Thank you so much.
Bye-bye.
Okay, thank you. Bye-bye.
So from our side, everything seems to be working.
Yeah.
You see the little mic?
Yeah, that works.
Yeah, so
but why doesn't he hear?
Is that he might have muted his computer or muted himself because he thought maybe like...
No.
He was unmuted.
He was unmuted, but he couldn't hear me.
No, I'm saying like for example on the Mac you can press like mute the sound. It doesn't mean that you're muted from your side. It means that like all the incoming sound is off. So maybe he accidentally like turned off the sound from his, and that's why he didn't have anything coming in.
My worry is that when Graham and Charlene come on, and we have the same problem, that they again, you know, I need to write them to tell them.
Are they available to do a little test run right now?
That is an idea. Let me see, Charlene. Where's Charlene?
The video is off, yeah? It stopped broadcasting, yeah?
I don't know.
I guess not, hello.
I wondered, I told her to be here. Actually, I told her to be here. Wait. This fucker goes onto Wi-Fi, which doesn't work.
Daniel, tu savo kompo čia neturi? Tu gal prisijung. You can invite Dennis and then we'll see if it'll work.
But can you go onto my... you have this old invitation.
Prie Zoom prisijung prie jo.
Yeah, hi Charlene. You're there?
Yes.
Could you come into Zoom because we want to test the sound? Because with Shekhar there was a problem. Okay.
Thanks.
Yep, okay, and I'll see you there.
Other than that, well, it's smooth.
Going okay? Yeah.
You were a rock star.
What?
You were a rock star. Your opening presentation was really strong.
That was good.
Very strong. You take orator classes or anything? No, just naturally.
Just doing a lot.
Yeah. No, because like some people you could see like they're good at what they do and they know a lot about the profession, but they just don't know how to get it out there.
Yeah.
For you, it doesn't seem to be a problem.
Well, you know, in school it was absolutely horrible. Ah. Yeah.
See, the mic's working. So.
You can hear me? Oh, she's connected. Who is first? Is Joey first? Yeah. Okay.
Okay.
Yeah.
Let me just do my video.
And can you hear me?
Yes, I can hear you perfectly.
Oh.
Can you see me?
No.
Why is it doing this now?
I don't see you at all. Ah.
Oh, there we go.
Yeah. Okay, good. Yeah.
So where are you now?
It's a bit vague.
Yeah, it's from the laptop. It's the only way I can actually share my screen.
Ah, and there's Graham.
Hi, Graham.
Hello, Charlene. Hi, Robert.
Good, I can hear you.
Hi.
Great.
Because with Shekhar it was a slight problem. He couldn't hear me, so I had to write him in chat what he was supposed to do.
Okay. Can I practice my sharing screen to see if it works okay?
Yeah.
Okay, time to get organized. This is just a practice. So I'll do share screen. Where is it?
It's at the bottom. It's green.
Right. You can see it, but I can't.
If you go to the bottom banner, mute, stop video, security, participants, chat, and then share screen.
Yes, I see.
I've done that. I'm just trying to see if it's got. I've done that. I'm trying to see on the options that come up then where my PowerPoint is. Good job on practicing it. Just a minute. Right, better close down some other things.
Coffee? Should I bring you some? Black?
Can you hear me okay?
I don't see anything yet. You have never done this before?
I have, yes, but it should. There we are. Yeah. Okay. So share. Can you see that PowerPoint?
Yes.
Okay, and can you see it on full screen now?
Yeah. You have full screen and then the three faces. So.
Okay.
When Charlene is talking, then you can disconnect your video.
Yeah.
And when you are talking, then Charlene can basically disappear, unless she wants to listen to you, but then she will disconnect the video.
Okay. All right, and then let's see how I stop that. Stop share. Okay, right, there we are, good.
And you, Charlene?
Okay, let's go for it.
Robert, are you the convener of the meeting?
Yeah.
Okay, so as I start, I'll do share screen, then I'll ask you, I'll check with you if you can see my slides, and if you can see them full screen as well. Okay.
Okay, can you see me?
No, you started screen sharing, it says, but for the rest, nothing. Ah, yes.
Can you see it?
Yeah, but then you need to go to slideshow app and then put it in full screen.
Okay, there.
Yeah, perfect. The only thing is I will then move the faces a little bit down. Yeah. Let me see. Yeah. Good. So I think we're all set then.
Yes. Must I stop share screening for now?
Yeah, yeah. So you have still, I'll be back in 10 minutes then, and then we can start.
Shall we stay online then?
Oh, you can go around.
Yeah.
Yeah.
Have a coffee.
Yeah.
Yeah.
I'll have coffee too.
Okay.
See you in 10 minutes.
Yep.
Do that.
I'll see you soon.
Okay.
Good.
With you again, because you are welcoming other people, sort of things.
Very good to see you.
Me too. This is a very good conference.
Yeah.
You bring out we keep the physical distance.
Yeah.
We continue we made social solidarities.
Yes.
For sheets, there's a global event, but yes, why there's no things related to I mean that the disease in China also very serious. The Chinese government's measure is very I can say very cool because all the thing the speaker speak here in China is all worried. You just lock the people out. They don't care. When 1 month, 2 months, okay. Nobody is. If those have disease, they are dead. Those no disease, okay, let you out. You go to coffee because you.
No, it's okay.
No. Still 2 hours. You cannot.
Okay. They will bring me a coffee.
You need some rest. I cannot.
You will be at the reception?
You mean the
after the conference?
I will maybe half hour because I have lecture in 6:30.
Yeah.
6:30 at the international organization. But I will go there. Yes.
Ah, okay.
And I still owe you the book.
That's okay.
No. That's
not
okay.
It will come.
Actually, I go last year, not this year. I go to your class, human rights, but few times, but I cannot meet you because I want to give you the book and talk about because I write you the email during that time. Just the Hong Kong event happens. I don't know you know or not. I am Cantonese. I mean in China there's two major. I am Cantonese. Half my family is living in Hong Kong. My grandpa have 11 child. My father is the smallest. 3 of his child is swing to Hong Kong, and his bigger sister. He failed. He tried 3 times, so he can't come back. And the thing happened in Hong Kong. You cannot imagine because before 10 years ago, you cannot imagine those things happen in Hong Kong. You know those violence and those. I mean, there is totally complete change. The city. Of course, sometimes I cannot understand my family because they seem to not care. They spend so. Sometimes I cannot understand how they think. The changes are very huge. So there I become not much. I think the human rights in China, you're doing. That regime is totally different from the South Africa regime. Sometimes you cannot use those methods. They don't care. Oh, you want to be suffer, you don't resist. You want to peaceful, resist, and you are not violent. Okay, that's much better. This can you out then. No, you go.
No, it's okay. But listen, send me an email and we can meet.
Okay.
I come in town very often.
Okay. Because you are very, very busy, I don't want to explain your...
It's a pleasure to talk to you.
Another thing is your institution in Vilnius.
Yeah.
No, I mean the not because you remember the last lecture you told your institution office, is in Vilnius or here, this university?
I live in Vilnius, but I work here.
You mean your office is in here?
I have an office here, yeah. In the
This university?
Yeah.
Can you give me the address?
Yeah, sure. It's on the, but it's across the street. It's on Dalkantor 27, a university building, and then on the 3rd floor.
Oh, okay. I can find you. I asked
Second floor for Westerners.
Oh, I always think you are in Vilnius, so...
No. So I come here 2-3 times a week. So we can meet, no problem whatsoever.
Okay.
Yeah?
Okay. No, you need to...
No, I will check my telephone.
Okay.
It's more important.
Okay.
Oh, thank you.
Yeah. So I'm shocked. I really expected that it's going to be a bigger turnout. I guess I should...
It's always like this.
Should expect like 100 people to sign up and only like 10.
Yeah. This is always...
It's insane.
And it's okay. It's about 35 people.
You know already how much are viewing it on LFA? Because on YouTube I logged in and I checked. It was like from the Badu. Because Badu is the one that's streaming. Yeah. It's like 9.
Okay.
So LFA is the big...
is Charlene Sunkel. Charlene Sunkel is a leading South African voice for the rights of people with mental health problems. She works for the South African Federation for Mental Health as a program manager for advocacy and development, authored several papers from a service user's perspective, has written and produced theater plays and a short feature film on mental disorders in order to raise public awareness. Mrs. Sunkel has been involved in the review and drafting of various policies and legislation in South Africa and provided technical assistance to international mental health related reports and documents. And she serves on a number of national and international boards and committees. Mrs. Sunkel was diagnosed with schizophrenia in 1991, which led her to her passion for mental health advocacy and human rights, where she received a number of national and international awards for her work. Charlene, the floor is yours.
Thank you very much. Just a correction, I no longer work for the SA Federation for Mental Health, but I'm now founder and CEO of the Global Mental Health Peer Network.
Okay.
Just going to share. Yeah, thank you for inviting me to participate in this conference.
Just a minute, your screen is not yet. Yeah. And then if you go to slideshow and then from the beginning.
All right.
You got it?
Can you see the slideshow yet?
Not yet.
Okay, it should be there now.
Yep. You can go ahead.
Okay. Right. Yeah, so it's afternoon. So I'm just gonna kind of start by kind of giving a bit of a background that just before COVID, globally, a lot of mental health advocacy initiatives driven by various stakeholders, including people with mental health lived experience, have highlighted, of course, the critical need to invest in mental health, to upscale mental health care and services, and to strengthen both health and mental health systems, and also to improve access. And of course, this with a consideration of a multidimensional and person-centered approach. And that means considering the social determinants of mental health, and also that every person is a unique individual with unique needs and challenges. And also, if we talk about services, we also need to know that it must take on a human rights framework. So also before COVID, globally, mental health systems had been inadequate. Unfortunately, human rights violations still ingrained in many practices, and people with lived experience with mental health conditions still being excluded. And then, of course, in various degrees across countries, some countries on these areas have progressed in different ways. So COVID arrived basically at a time, when health systems in many instances were and still are weak and unprepared to deal with the mental health implications of COVID. So I would like to see this more as an opportunity right now to put into action and address what we already know. And I'm referring to points 1 and 2 that I've spoken about. So people with lived experience, just want to get here, face a concerning impact on their mental health at various levels. Not only now, but we can expect to see an impact that potentially exists post-COVID. So I'm just going to go through various levels of impact. If we look at systems level impact on people with mental health conditions, what we've seen is there's been disrupted and suspension of mental health services, and that includes admission to hospital care. And for many people, inpatient hospital care is kind of a life-saving intervention. So we've seen that that's been limited where they admit patients. And also disrupted public transport. And that causes another problem of people accessing services at community level or wherever they need to follow up on a monthly basis or for emergency intervention. Another issue, of course, is the loss of income for those who've been employed and lost their jobs, but also for family members who were looking over carers and who lost their income. So that again poses problems in terms of affording transport to access services. Some people had to purchase medication privately because there's been report that there was medication shortages or stockouts of medication, and others where they could have accessed kind of virtual services and remain connected. Some can't now, due to loss of income, afford data and airtime. And in terms of technology, especially in rural communities, there's often a lack of or very poor internet connection. So that also makes it very difficult to access virtual services. And that includes like remote consultation sessions and support services, and as well as peer support. And for those living in residential and inpatient care, where there's shared spaces and often overcrowding, the risk of outbreak also causes some problems in terms of them makes it very difficult to practice precautionary measures. And that includes physical distancing, and often we've seen that some of these facilities, there wasn't provision for protective gear. And then just to briefly go over the COVID risk, infection risk of people specifically with mental health conditions. We know that people with severe mental health conditions are particularly vulnerable, and they have worsened outcomes or suspected worsened outcomes of COVID infection because of comorbidity. A lot of them have a mental health condition, some also other conditions like obesity, diabetes, high blood pressure, and so forth. And that's also because of poor health. And that can be because of medication side effects, lifestyle factors, and also to access general services for their physical health conditions. Another problem is concentration and memory. And that's also one thing that I struggle with a lot, or other cognitive functioning problems where it's very difficult to comply with precautionary measures. For example, now you need to remember you need to wear a mask, you need to wash your hands regularly, you need to keep physical distancing when you're among people. And then in rural areas, we see where there's often a lack of sanitation facilities or running water, people are unable to practice hand washing, frequently hand washing, and washing their fabric mask that they use daily on a regular basis. Rural dwellings, which we in South Africa call shacks, are often overcrowded. The whole family stays in a very confined space, which also makes physical distancing impossible. The other thing that we also deal with is myths around COVID, and just to mention one, in Africa, for one, especially in the beginning of COVID, there was a belief that Black people were immune to COVID. So access to information is also very important in how it is conveyed, especially to people with mental health conditions. Then if we look at specifically the mental health risk of COVID on people with existing mental health conditions, definitely what we see is worsening of symptoms to a range of factors around COVID, and also related to increased anxiety, social isolation, helplessness, and also to the extent of suicidal ideation. Conspiracy theories that went around, especially in the beginning, also didn't make it easy, especially for people who are affected by paranoia or conditions involving paranoia. So that just increases that and increases the fear. I think people with obsessive compulsive disorder and anxiety conditions, and especially related to hygiene, also particularly went through a very difficult time, and especially still now. Of course, the economic impact, what I would actually say is probably the biggest impact, it creates a lot of fear for the future. And for people with mental health conditions, the fear in terms of economy, related to economy, was already kind of grim due to stigma discrimination. For example, people already before COVID found it very difficult to obtain employment or to access education. And now the economic impact and future just makes it so much worse and just creates further uncertainty and hopelessness. Those who lost loved ones, their grief has been intensified, especially because they weren't able to say their last goodbyes in hospital to their relatives because of there wasn't allowed visitation. So that also creates a lot of issues, mental health issues. And then I think also a big one is the constant reminder of COVID in the media. When you switch on the television, when you go online, when you read the newspaper, everywhere it's constantly COVID-related issues. And it becomes very overwhelming, and it just increases emotional distress. Just specifically in terms of the country response related to lockdown and quarantine measures, that had a specific impact on people with existing mental health conditions. You can imagine it's I would almost say it's like haunting visions. All of a sudden, the streets are empty. People are frantic over purchasing essential items. And of course, the economic activity that came to a standstill. All these issues can be very traumatizing. And adapting to a new normal, if we can call it that, is very difficult for many people with lived experience. I think we as with lived experience, we often find it very difficult to adapt to new circumstances, and it causes a lot of anxiety. But I think even for anybody else without a mental health condition, it's difficult. Isolation, especially those who've been found it very important to remain connected to prevent loneliness. It's been specifically difficult. Then you find other people, like myself. I didn't find it so difficult, isolation so difficult, like lockdown measures. But all of a sudden, I actually had an excuse not to go out or not to meet with friends or to talk to anyone or see anyone. But the danger of that is it creates an unhealthy habit of isolation. I, for example, now find it very difficult to go back into kind of my social life, for example. And then lockdown, and that I'm referring to specifically people who are in residential and inpatient care facilities. They specifically find it very difficult because they are disconnected from their families and friends, where visitations have been prohibited. And you can imagine they feel isolated from the outside world. I'm just gonna briefly sketch, I just want to give you a bit of context on the difficulties I experienced specifically as someone living with schizophrenia. Especially in the beginning, even before COVID, I've been living with schizophrenia for 30 years, and almost my daily life consists of doing reality checks, making sure everything around me, what I hear, what I see, what I think is real. So you can imagine now with COVID, all of a sudden everything has changed. So it's a very surreal situation. And I found myself to be very confused. And I actually found it difficult to distinguish between what is real and what is not. I even battled with some weird thoughts and trying to make sure that I don't fall into those thoughts. And I can just mention one thought that kind of crossed my mind often, which is of course unrealistic, is that someone implanted COVID into me and using me as a weapon to kill people. And that caused a lot of guilt, although it's unrealistic. So luckily, I am at a place in my life and with my condition that I know and kind of can reason with myself what is real and what is not. But COVID just made it very much more difficult to actually do that. What caused a lot of anxiety for me as well is to remember all the checks of precautions. I had to remember, wash my hands regularly, every time I touch the surface, and wear a mask, and keep my distance around people. So all of that creates anxiety as well. And it's something that I kind of learned over time. Now it's kind of normal, but in the beginning, it was very difficult. I also became later on very obsessed with cleaning and hygiene and disinfecting everything. I was already obsessed before COVID, but now it's just so much more intense for me. And for me, as I mentioned before, I'm kind of a person, I'm not very social, so I kind of love my alone space. But I kind of fallen into that antisocial behavior, and it's going to be difficult for me to get out of there again. And what I found recently, now that lockdown measures has been kind of relaxed a lot more, that we now go out and can go to the shops and all that, I find that I kind of become a bit anxious when I go out, especially having people around me. And I've noticed also that I'm quite sensitive to noises. Like when you go to a shopping mall, there's all these noises of people talking, footsteps and all that. So for me, that is something that is a direct result of being in lockdown for so long. And then I also mentioned to you that COVID being everywhere. And funny enough, we spoke a lot about it with people with lived experience within the Global Mental Health Peer Network. And we've all found it to be a specific issue of constantly having COVID in your face. So a lot of us actually went to the measures where we limit watching the news or limit going online or looking specifically at news or anything related to COVID. I just want to jump one thing. Just in terms of that point that I made about COVID being constantly in your face, in partnership with Mind the Gap campaign and FGIP, the peer network will soon be coordinating what we call a kind of care for a cuppa, which is like a virtual coffee shop. The idea of that is a lot of people have been isolated and kind of lost that connection with friends and relatives. So this coffee shop is there so that people can come together and just talk about anything unrelated to COVID. Share what you did today, whatever your interests are, hobbies, just to have a nice chat and kind of enforce that connectedness. So I think we could have done a lot better, but in the response to COVID, but it's definitely not too late. And I think just to highlight a few important points, I think right from the beginning, the response has not considered mental health needs, including lived experience, perspectives, and involvement in the development of guidelines and the response measures taken, and to consider it specifically in the context in which people with lived experience find themselves, whether they're in residential facilities, hostels, in the community with family, and so on. And peer support work, I think, is a very undervalued and under-recognized, I'm going to call it a discipline in mental health, unfortunately in most countries. And if we had an established workforce of peer support work in the mental health workforce and integrated into this response, I think we would have made a lot of difference in many people's lives, having that connection of a peer. For example, the peer support, the Global Mental Health Peer Network, we have started a virtual support group, specifically mental health and COVID support group. And just that support group for peers coming together and talking about their difficulties during COVID has made a huge difference in their lives. And I think we should make a much better effort of encouraging social connectedness. And that is also what Mind the Gap is all about. and to make provision for access to technologies. Even though we are from poorer communities and rural communities, that stakeholders need to come together and make provision to get people to be able to access these technologies, to be able to kind of participate in virtual support groups and consultation sessions. I mean, the technology has been there and available, and I think in mental health specifically, it's an opportunity to use it effectively. And then people with lived experience, also with some of the members of the peer network, we've had some discussions of looking beside the negative impacts of COVID. And we actually came upon the idea that we actually all learned new ways of maintaining well-being. We even learned new skills. Some of the guys actually said that they learned cooking, they learned all kinds of skills. And I think we mustn't forget to look at that aspect as well, and what can we learn from that and incorporate that into COVID response, but also into responding to mental health going forward. And of course, we need to get the language correct. And that's again what Mind the Gap is all about, is to use the phrase physical distancing and not social distancing. We want to encourage, again, people to stay socially connected, because social connectedness is so important to kind of facilitate well-being and mental well-being for people. Thank you very much.
Charlene, if there are questions, would you be willing to take one or two?
Yes, absolutely.
Yeah? Are there any questions to Charlene? Yeah, Ineta.
Well, first of all, thank you very much. And I think that it was so sensitive that you shared your personal experience. I would like to thank you for that. So just very short remark.
Thank you very much for that.
Charlene, I have one question to you. So if you look back, would you like to go back to your life before COVID, or has something fundamentally changed that you said never again, or not back again?
I think there's a yes and a no. I think before I used to travel like every month. It was quite tiring and exhausting. So it's quite comfortable for doing Zoom meetings and online meetings, but even that becomes very tiring. But I think in terms of traveling, where I traveled a lot, instead of traveling now doing online, I have a lot more time to attend to my work. So in a way, I'm actually less stressed because of having a bit more time and also a bit more time at home. But I think also after COVID now, looking back, in a way, I want to stay it like this, have it stay like this, or not completely like this, but to extent, because I've seen communities come together. Even if you look in the building where I stay, it's been absolutely amazing how we all supported each other. If this one goes to the shop, they buy for everybody else, so that everybody doesn't need to go to the shop. Just to see how communities come together, we speak of solidarity. I think that part of it, I would like to remain.
You have two parents. Are they happy that you're at home all the time or not?
Yes, of course. Yeah, they're in 7th heaven because I'm now at home, and they are less stressed. So I'm happy about that.
Okay, Charlene, thank you very much.
Thank you.
Now let me see how we get the next one. Graham, you can hear me?
Yes, I can. Hello, Robert.
Hi there, hi there. So let me introduce you first, and then I give the floor to you.
Okay.
So Sir Sir Graham Thornycroft is Professor of Community Psychiatry at the Centre for Global Mental Health and the Centre for Implementation Science at King's College in London. He's also a consultant psychiatrist working in an early intervention community mental health team in South London. And he's chairman of the board of the Federation Global Initiative on Psychiatry. His areas of expertise include mental health-related stigma and discrimination, development of community mental health care services, cost-effectiveness evaluations of mental health treatments, and global mental health. Graham, let's try to get your PowerPoint online.
Okay, thank you very much for that kind introduction, Robert, and good afternoon, ladies and gentlemen. First of all, I will now show my PowerPoints. And let me check, Robert, can you see this coming up full screen in a moment?
Yes, it's on screen, but you can now go to slideshow.
Yes.
Yeah.
Is that on full screen?
Yeah.
Great. And Robert, if you can help me, please, in case there's any PowerPoint problem.
Yeah,
Good.
yeah, sure. I'm around.
So, hello, everybody, and thank you very much for inviting me to speak at this important memorial conference today. So I'm speaking to you from London for all the reasons that you know about, and I'm going to say something about a global perspective on COVID and mental health and how these interact in sometimes unexpected ways.
Graham?
Yes?
You are in presenter mode. Can you go to normal mode? Or
can you see a full screen, same plan?
I see also your next slide. No notes.
That's interesting. Okay.
So
right. Excuse me, ladies and gentlemen. Let me try to remedy this. Now, is that a full screen mode, Robert?
No, it's again next slide. So
okay.
Otherwise keep it in the other mode like this.
Yes. So in that case, I'll leave it in this mode. There's a slight technical problem. Is that readable?
Yeah. It's fine.
Great. Okay. Right. Sorry for that. I hope that you can see the slides clearly.
Sure.
So, just let me check. Can you see a slide saying plan?
Yes.
Great. Okay. So I want to do three things in the next maybe 15 or 20 minutes. First of all, to say a little bit about the wider context of the field that is called global mental health. Of course, we're all a part of this, whichever country, whichever sector we are within. Then I want to say something specifically about how COVID-19 is having many and often negative impacts upon the mental health field. Then I shall say something about what I think we need to be doing positively to respond. So first of all, the challenges we face. I can summarize these in two ways for the wider context. The first is what's sometimes called the treatment gap or the mental health treatment gap. And I would call this, first of all, the mental health treatment quantity gap. And what do I mean? I mean that in all of our countries, wherever we are, the large majority of people who have mental health problems and who need help actually get little or no help at all. So let's take one example. This slide shows rates of treatment here, treatment at all, consistent with international guidelines and standards for three types of condition. The information comes from something called the World Mental Health Surveys, coordinated from Harvard University, now bringing together large-scale household surveys in over 20 countries. Over 50,000 individuals were assessed to produce these results. We can see on the left the rates for anxiety, and the dark blue shows the rates of treatment in the rich countries, so-called high-income countries, and the light blue shows the rates of treatment in low and in middle income. That means in the poor countries of the world. The best we do is about 14% in the rich countries, 2% of people with anxiety disorders in low-income countries are treated. And similar for depression and substance use, that means alcohol and drugs. So overall, we can say that in the rich countries of the world, about a quarter of the whole population this year has a mental health problem serious enough to need help, treatment, care and support. And of that quarter, only a quarter actually get any help. In middle-income countries, it's about 10% of people with problems get help. In low-income countries, perhaps 1 or 2%. So the first issue of challenging that we need to address is the small, indeed the tiny number of people needing help who actually get it. The second issue I shall call the quality gap. For those people who do get help, for example, in mental health services, or for some people in primary care services, is it effective? Is it of reasonable or good quality? And often, indeed too often, the answer is no. This is one of many images produced by Robert Van Voren, our host today, in a European country. And this is a psychiatric institution which looks very much, in fact, like a prison. So when people who have mental illness may be reluctant to so-called seek help, there may be very good reasons, because the type of help actually being provided is of indifferent or bad or terrible quality. So the wider context of these two gaps of not enough care, the quantity gap, and not good enough quality of care, the quality gap as well. So this is the situation before COVID-19 struck at the beginning of this year. So what's the impact then of this pandemic in relation to people with mental health problems and in relation to services for people with such difficulties? So I'm going to refer to points from a few recent papers that I've been involved with, working with colleagues around the world. This is a paper led by my colleague, Dr. Vigo, working in Canada. And this is a paper, also Dr. Vigo, and with a colleague, Professor Gureje, working in Nigeria. I shall summarize some of the main findings from this work. I shall do this in 4 ways. Firstly, the mental health impacts for the whole population. Secondly, people who had, before COVID, pre-existing mental illness or mental health conditions. Third, people working in essential services, sometimes called first responders. And then in relation to people infected by the COVID-19, by the coronavirus. So let's look at the whole population first of all. Well, I'm not sure if your situation is the same as in this country, in England, in the UK, and in many countries, where there was an immediate spike or fast rise in what's sometimes called health anxiety. And we heard a lot about this from Charlene. People uncertain, worried, feeling insecure, and then leading to behaviors to protect and to try to put in place protections against the future. For example, mass shopping, stockpiling on dry goods, on fluids, on essential items, on toilet rolls, and so on. Then there are people who have, either through disability or disease or death, suffered trauma in their own family, in their own community circles. And for some, multiple loss, multiple trauma, overlapping layers and depths of grief. For many people as well, in the initial phases, whether this be in self-isolation for people with infection or possibly infected, whether it be quarantine for those traveling across borders, whether it be in some sort of protection for people who are in vulnerable groups, let's say the elderly with pre-existing conditions, an increase and often a doubling of the rates of anxiety and depression and insomnia and irritability. And also data now from this country are near doubling of the use of alcohol for many groups as well. Now, these are the immediate impacts. In fact, we may conclude in future months and years that these may be small in relation to the longer term impacts of economic damage to our economies, our communities, and our societies. It's interesting as well to see that the way in which the pandemics have hit many countries has been different, and sometimes very different. So we compare the pattern here, for example, for India, of a slow start and then a catastrophic rapid rise in the number of cases and increase in number of deaths. From other countries, you can see here in my own United Kingdom, with a rapid initial rise and then a slowing down. But in fact, now we have news today that there may be up to 50,000 new cases a day within a month in the United Kingdom as the second wave begins to take effect. So although I'm making general points in this talk, one has to look at the specifics, not just of each country, but each community, which vary a lot about the impact, the trend, the attack of this virus. So this is one example of how this is affecting, in this case, 3 very different types of country. This is a United Nations survey looking with a standard measure of stress or distress, in this case, across 3 countries early. This was May in the pandemic. One can see rates from 35% in China of the whole population up to 2/3 nearly in Iran. But we can say that about half the population are affected in the acute phases of this pandemic. This applies, of course, not just to adults, but also to children. Here are data from Spain and from Italy, again in the first 2 or 3 months of the pandemic, about the impact on young people. High levels of loneliness, which one wouldn't necessarily expect among the young, nervousness, restlessness, irritability, and almost 3/4 reporting difficulties in concentration. Now, in some countries, children are going back to school. We don't yet know whether concentration levels will go back down to the level where they can successfully not just continue their education, but actually catch up with the lost time from their education in the last 6 months. We're also beginning to see trends in the occurrence of mental illness in the whole population. And just last week, here's a paper published from my own country looking at the findings since March. And it showed that in the first 3 or 4 months after the COVID pandemic began, there was an increase in psychological morbidity, and almost doubling, and particularly higher rates in young people, women, and who are those at risk. Interestingly, these rates of increase in anxiety and depression in particular did not affect those aged over 50 or 60 very much. So it's younger people, early adulthood and middle adulthood in particular, as well as teenagers, who are most affected in terms of age. But we may come to see in future years, in fact, the biggest danger to mental health from COVID and indeed from similar pandemics is that of suicide. This shows the shape of how suicide affects my own country. You can see it affects men 3 to 4 times more often than women. This is death by suicide. And we can see the pattern that changes over the life course, particularly affecting middle-aged men most, as well as an increase then in the older years, 80s and 90s. And we've seen, certainly from previous periods of austerity in Europe from 2008 and the following years, an increase among especially men in death by suicide. And the key risk factors appear to be low levels of social support, unemployment, and also insecure employment. So it's not just losing a job, it's fear of losing a job as well that can drive people to take their own lives. And indeed, 2 of the researchers in this field concluded from a review of economic recession and suicide studies. Recessions can hurt, but austerity kills. So the way in which governments respond to recessions, whether through stimuli packages and investment or through economic cutbacks and austerity, can make a huge difference to suicide outcomes. Secondly, I want to talk about some of the important effects of COVID on people with pre-existing mental conditions. That means pre-existing before the COVID pandemic. And we've seen that these people are often at risk, first of all, of being infected by COVID. Why? Because compared with the general population, people with severe mental illness more often have comorbid severe physical illness, and indeed may have 2 or 3 long-term conditions or more. Also, they may well be in settings with relatively low rates of protection. For example, in institutional settings, maybe in jails or care homes or long-term hospitals. And their care, for example, the provision of proper disinfectants, sanitization, and personal protective equipment may be given a lower priority than for people with physical conditions because of structural stigma against people with mental illness. As Charlene mentioned, if people require regular supplies of medication, these may be disrupted during problems with logistical supply chains during the sometimes chaotic reactions to the pandemic. Third, a word about those providing essential services, not just in the health and social care sectors, but also, for example, in transport, in public transport, in the supply of food to supermarkets, and those working in the food and other retail supply chains. Many, for example, many nurses, many doctors, many cleaners in hospitals report this as being the most difficult working time in their lives. Not just exposure to the virus, not just exposure to seeing people die, sometimes exposure to seeing many people die, but also being asked to work long hours with no breaks and no holiday. So the accumulating stress is actually intense. And there are also examples now being published of healthcare workers taking their lives as a consequence of these unbearable levels of stress. One particular source of difficulty is sometimes called a moral hazard. This is healthcare staff, maybe planners, maybe managers, essentially being asked to make either impossible decisions or decisions with a depth and a seriousness of their moral dimension way beyond their training or their experience. For example, there are insufficient ventilators or intensive care unit places. How should one prioritize and who decides? Well, in the short term, doctors, managers, nurses are being asked to make those impossible decisions and often feel terribly stressed and guilty by the decisions that they take. And all of these pressures are more intense in low resource settings, where there's still the relentless pressure of people requiring assistance, but far, far fewer resources to respond. And fourth, what about people who are infected by the coronavirus and develop the COVID-19 condition? Again, high rates of what are called common mental disorders, but also we're learning gradually they may have neuropsychiatric complications. For example, long-term fatigue, for example, cognitive impairment, stroke, and so on. There are also then implications for their family members who may be having to do extra at home if somebody is in isolation or quarantine, and who therefore, as family members, may not be able to work and so suffer economic difficulties. And we're also beginning to learn now that many people who have or who have had the coronavirus infection are stigmatized against. They're feared. They were expelled from their communities. People feel that once you have the infection, you will always be infectious. So social isolation at exactly the time when you most need social support. So far, this is all quite negative, I'm afraid, and this is a very, very difficult situation across the world, as you know. So what do we need to do? What do we need to do together. Well, here we've had a strong response from many influencers, thought leaders, public figures, including the royal family, focusing specifically on mental health. And we've also seen strong reaction from the United Nations and from the World Health Organization, of course, a part of the United Nations, with a report published by Antonio Guterres, the Secretary General of the United Nations, in May of this year. I'll just tell you a few of the headlines from this report. It's important to realize that some of these measures will be much simpler, difficult, but still much simpler to implement in the rich countries. And some of the required measures are difficult, maybe impossible, in some low-income settings. So, for example, if you live in an informal settlement or in a slum, whether this be in Sao Paulo or in New Delhi, then it's simply not possible to physically distance from other people around you. Similarly, the idea that you might stay at home and not go to work depends on the idea that you have a salary or salary support or replacement. But for example, nearly 90% of people in Africa who work in the informal economy. If they do not work for a day, they do not get paid for that day, and the family depend upon that subsistence income. So let's take a moment just to realize this is very much dependent upon the economic as well as the health and social contexts. So what did the United Nations say? Three things. Don't think about this as separate things, isolating, washing hands, masks, but take a whole of society approach. Second, emergency response means considering both and integrating both physical and mental health types of support. And third, the idea that we can actually learn and try to improve services after the COVID, not simply see them damaged and then try to repair to what they were before. So I'll say a little bit briefly now about each of these. The whole of society approach, what does it mean? It means including mental health in every aspect of measures to respond to COVID and measures to build in the future. It means thinking about the wider implications in social and family terms, like the increase in many countries of domestic violence and violence against women, while people are quarantined or isolating at home. And also taking into account the likelihood of increased anxiety in the population, so that the governments need to focus on simple, clear, consistent messaging. Second, thinking about emergency psychosocial as well as emergency physical support. As again, we heard from Charlene, one of the biggest implications from social isolation, for some, not everybody, for some people, is loneliness. And that exacerbates anxiety, that exacerbates depression, that may increase the risk of self-harm or suicide. And at the same time, keeping a very close eye upon the human rights dimension, again, as Charlene mentioned. Are we treating people in mental health institutions and hospitals on an equal footing with equal rights and equal investment to people in physical health institutions? And thirdly, the idea, quite often called this is called building back better. It's an idea that came from the time of President Clinton. It really grew at the time of the Aceh tsunami, following the earthquake there, that what we can learn is to create services during the pandemic or the crisis that will actually, in the long term, be better. In this case, by integrating psychosocial support into general health care, not leaving this second, isolated, or underinvested. So these points are also reinforced in another recent paper looking at the health system effects of COVID. You can give you some of the key points here. And if these papers are interesting to you, I'll give you my email address in a moment so you can write to me and I can send the papers to you. More generally, if we're thinking about global mental health, I think a great place to start, if you're interested in the field, is to read this Lancet Commission on Global Mental Health and Sustainable Development, published just 2 years ago now, but still right up to date with its review of the whole field of mental health in the world and a clear vision for future improvement. So to summarize, what I've wanted to do is to give you a type of panorama or overview of how COVID is attacking systems that have gradually been improving in many countries for mental health and risks undermining so that we go backwards and not forwards in improving mental health care. I've talked about different groups, the general population and so on, as we've gone through these key issues. And I wanted to highlight a few particular important areas, but of course, I haven't been able to mention everything. I've also mentioned in particular this report by the United Nations published in May of this year, which I think is a very helpful starting point about the actions that we need to take, in this case, perhaps at regional or at country level, to mitigate the damage of COVID for mental health, and indeed, if possible, to harness the potential for improving services in the future. And I'll finish by saying that I think mental health, in fact, is the hidden COVID crisis. And we're only just beginning to appreciate the importance of this in the short term. And I think this may be magnified in the long term. And colleagues in China have given the situation a different name. They called the COVID period a parallel epidemic. So if any of this you'd like to hear more about, if you'd like any of the papers or the sources, I'd be happy to send that to you. Simply write to me. You can see my email here at kingscollegelondon.kcl.ac.uk. Thank you very much for your attention, and I now pass you back to Robert van Voren.
Thank you, Graham. Let me see if we can get you back on screen. Are you ready to answer a question or two?
I am, and I'll try and take the PowerPoint down as well.
Yeah. So, are there any questions? Thomas.
Yeah, thanks. You were the first one, if I'm correct, to mention China, since we in the West are more on an individual rights perspective when it comes to human rights, and the Chinese prefer the community as, the general the human rights. What is the main difference in the China response? Why are so few people dead in Wuhan and those centers in which are densely living populations, very overcrowded cities as compared to the European situation? So maybe you can enlarge a little bit more on that topic.
So, Robert, could you please relay the question to me? I didn't understand all of it very clearly yet. Thank you.
I try again.
Perhaps, Robert, if you can summarize the question to me, please.
Thomas very much would like to know what the difference has been in response between the one in China and the one in, for instance, Europe, with regards also to the number of people that have died because of the response.
And are you asking me to give us an overview about the different responses?
What your view is about the difference in approach.
Okay. So let me give you one example. Early in the pandemic, we had a story in the newspaper in this country of the China correspondent for a national newspaper who had returned from Wuhan to Beijing, and she had to self-isolate, I think, for maybe, let's say, 10 days. So her front door was locked by the local security personnel. They came to her door every day to check she was still there. A neighbor came 2 or 3 times a day to speak to her to check she was still in her house and not dying if she needed anything. And she was physically not allowed to go out. So there was no room for that person's discretion or judgment because they were made to self-isolate to stop transmitting any possible infection to anybody else. Compare that with the situation in my country, where we had a news story this weekend that of people who tested positive recently for COVID and who were therefore advised to self-isolate, to stay at home for 2 weeks and really to have contact with nobody. In fact, only 20%, 1/5, followed that advice. So 80% who did have a positive test were mixing with other people. Now, I'm not suggesting that we should take a totalitarian approach to this, but I am suggesting that we need to think carefully about whether we're serious about the basic epidemiological steps. And they all have to be in place if we're going to reduce the incidence of infections and get control over the spread of disease. And you know the basic steps. It's testing widely for people who are or who may be symptomatic or positive. For those who are positive, with or without symptoms, they need to be isolated from other people. All their recent contacts need to be identified, and all those contacts need to be tested until the test results are available. They need to be assumed to be positive, and so on. So you have a chain, you need to cut the chain of infection, and you need to do that consistently across a population, and then you can hope to get control of the spread. And what we've seen in European countries in the last 2 months is reducing of lockdown, people going on holiday across borders, children going back to school, students now going to university, people being advised to go back to the office and resume work, all for excellent educational and economic and social reasons. And now we're seeing the numbers per day in many European countries are rapidly increasing again. In my country, it's gone from 1,000 to 2 to 3 to 4,000 new cases a day. Today, the chief medical officer of this country predicts up to 50,000 new cases per day within a month, unless we take further measures to reduce the chain of infection. So I think we have to take this extremely seriously, because once it gets out of control, it's like a wildfire that can spread across all of our people and all of our populations. I hope I've answered your question.
I wanted to know a little bit more about the different approach of human rights as individual rights first or collective rights as opposed to the Chinese approach, and whether the Chinese model wouldn't only make sense in which the risk herds are confined in a certain physical area, which is not the case anymore. So this kind of approach is also practically impossible. It's typical for a totalitarian system. I mean, to just lock somebody in, and also the police force is quite different in China, and also the surveillance system and all that. Those are infrastructures that are correspond to totalitarian systems, which we of course reject with for some reason.
You got that one, Graham?
Not quite, no. Could you summarize, please, Robert?
Yeah, so basically the question is, again, the balance between the, say, Chinese totalitarian approach, where you lock people up, which is possible when it's a contained area, becomes very difficult when it's as widespread as it is now, and the individual human rights of a person.
Yeah. Well, this, in principle, this isn't a new challenge, because certainly my country, I think many Western European countries, do have regulations or laws which provide, for example, for a person who may have HIV or TB and so on, who is willingly going out to infect others, to be stopped from doing so. The difference here is the scale of the risk. So the Western tradition, at least in many European countries now, is of government by consent. And in practice, what does this mean? It means the government seeking to persuade the people to do the right thing, and then usually reluctantly bringing in special powers and laws where that isn't sufficient. Again, I'll take an example from my country here. The first 3 months, the government gave people a very simple, clear message: stay at home. And they explained why. And many people knew or heard of friends or family or somebody at work being affected, occasionally dying. So the rationale, the meaning, the reason for this was clear. So the trust of the public was reinforced by a realistic, clear, consistent, understandable message of what to do and an understandable reason for why to do it. Now, I think in some countries, maybe including this country now, we've seen a weakening of the clarity of the message for behavior and a weakening of the clarity of the message for the reason for the required behavior. So now this government here and in other countries, I think, are beginning to bring in laws because the guidelines, the guidance, the requests of government haven't been sufficient. And I think we're at a dangerous point in two respects. First is the breakdown in the control of the numbers of cases. And second is a breakdown in the widespread trust in the government among the public of the messaging. So we're now seeing in this country people going out when the sun is shining to parks, to beaches and so on, and mixing in very large numbers despite clear government guidance. We're seeing young people going to university, sometimes mixing in social groups as they would normally do, but not modifying their behavior for social distancing because of the risk of the pandemic, of course, which is far less of a risk for young people. So I think that we've got a real balance to make. And I think it's extraordinarily different for governments to know just how far to bring in strong and legally binding measures and to implement them, or whether to try to trust that the people will follow clear guidance. But at the moment in my country, in my experience, is the guidance is not succeeding.
Okay, thank you very much, Graham. I know that you need to go to a next meeting, so you can zoom away. And thank you very much for your participation.
Okay, all the best to you. Thanks. Bye-bye.
All right. Okay, then I would now like to give the floor to Leonidą Donskį as the last speaker. She is the former Vice Rector for International Relations. Oh, you're still the Vice Rector for International Relations at Vytautas Magnus University, Professor at the Department of Lithuanian Language, and Head of the Research Center for Intercultural Communication and Multilingualism. The floor is yours.
Yeah, good afternoon, dear colleagues, ladies and gentlemen, friends. I'm not an expert on this field, neither on practical level or theoretical. I'm here most probably because of my status as administrator to announce about the new initiative that Robert already has mentioned about the new platform for the university. Well, there is no way to deny that COVID pandemic is a great challenge on a scale that is hard to imagine. It affects all spheres of life on various levels, and it was mentioned already today. But in each crisis, there is a possibility to not only find something that helps us to overcome the challenges we face, but also create something that allows us to grow in a variety of different ways. And it was mentioned again today by speakers of this panel that solidarity and community, this is something that we should rely on. Mind the Gap campaign has allowed us to see how careful we must be with our words and meanings beyond them. Used without careful consideration, they can push people already at the margins of the society. The pandemic has serious consequences, not only for senior or disabled, but for the younger generation as well, those who are now part of our constituency. In the short term, their career prospects have been rather shaken, but in the long term, they are looking at a world that might be quite different from the one they saw when they planned their future. This uncertainty has led to increased levels of anxiety and depression, but also to a wish to understand what's happening as an essential precondition to future planning. This is highly relevant as the pandemic uncovered a lot of problems that have been neglected during more peaceful times. How conditional and flawed certain democratic processes are. How the systems of healthcare and human rights are ill-prepared to deal with large-scale challenges or offer urgent solutions. How political leaders are inconsistent in their approaches, and how people fail to understand their own personal responsibility in the big picture of things. Universities carry responsibility on so many levels as well, not only as institutions of research, educators of young, clear-thinking people, but also as actors of the society at large. More importantly, they need to consolidate their potential to deal with large-scale issues at hand. A great way to embody the power of this message occurred in the context of other initiative that encourages European universities to form powerful and transformative alliances. Our university belongs to one of them, the alliance called Transform for Europe, that unites 7 universities from across Europe in their attempt to create one joint sustainable European university and provide both students and teachers with wider opportunities to collaborate on global agenda. The partners of Transform for Europe have therefore created a strategic and sustainable alliance to educate motivated and skilled European knowledge entrepreneurs, agents of change with the interdisciplinary, digital, multilingual, and intercultural competencies needed to contribute to and shape upcoming transformation processes in Europe and beyond. Recent years have witnessed a lot of discussions about what the future of education is supposed to be. But the global pandemic has exposed that the theoretical level of these discussions is no longer enough if we want to ensure the true university education, its diversity and relevance. We need to create not only new forms of study and research, develop new concepts for mobility, but also to find the way how we all, teachers, students, and others, will interact, and how we'll ensure the humanistic approach over technological. As one of the ways to contribute to this dialogue, our university initiates a special Mind the Gap University platform that could be developed with a broader focus on social solidarity and emotional well-being. The platform invites the European universities to collaborate and foster changes in several themes. First of all, we need to look at the situation and call for careful analysis. What happened and what could be done? Of the challenges the pandemic has stripped for democracy, the integrity of the personal space, EU collaboration and integration, and the role of the current superpowers in the world that is now being created. We need to study and discuss the conceptions and perceptions of normality, not normality, or even new normality. The pandemic has resulted in a lockdown of half of the globe's population, into emergency measures of varying degree, in restriction of movement, both internationally and nationally, which exposed the vulnerability of youth as a group. This platform will emphasize the importance of a dialogue and youth engagement in rebuilding cooperative, peaceful, and diverse Europe. And it will try to enable the voice of youth to foster taking personal responsibility for the future, to gather peers and build a sense of community for Europe enthusiasts. With the scope of the area of the life COVID affected, the platform might naturally develop and incorporate a lot of new topics. The main principle, however, is to remain reflexive. And I would like to already mention that we have started and initiated already several activities, and we hope to elaborate and expand them. For example, we have organized and initiated so-called dinners for change makers that Robert with colleagues have organized in spring. We already contacted embassies and ambassadors to be part of this big initiative for youth. So I hope that some other ideas will come and, as I mentioned, will be expanded. I believe that just like in any other difficult situation in history, together we can more. And in the very last message, I would like to say or remind you that this is the day when we lost Leonidas. It's still very hard on many of us because he was a great colleague, very close friends to many of us here sitting. And it is a gap, still very big gap, on very many aspects, on personal but also on societal. So I would like also to thank Robert for taking a leadership for initiating this idea to have this conference to commemorate Leonidas' legacy. So thank you, all of you, for coming here, to contributing to this very interesting conference. All the speakers of both panels were very, informative, and we really appreciate all of your support. So, Robert, thank you, and thank you, all of you.
Thank you, Ineta. So I would like to ask the three Lithuanian speakers of today to come on stage for the last part, which is a brief discussion. And at the end, I want to show you one more of the Ukrainian clips, which was just produced over the weekend, or finished over the weekend. So, in trying to summarize the day, I would like to ask each one of you to reflect briefly on, I think, two issues which were very much a kind of center part of Graham's presentation, and also his interaction with Thomas Pfanne, which touches upon one of the key issues that we've been discussing the whole day, which is human rights. And to give you an example, in the Netherlands, there is a movement called, it started with the name Virus Madness, and now it's called Virus Truth, which is a weird collection of people that believe that there is no COVID pandemic, or it's just created, it's fake, or it has been created on purpose in order to get us under control. It includes anti-vaccinists. It includes people that think that we will be implanted with a Bill Gates chip, so we will be controlled. And their main issue is that the instruction to wear a mask in public when you're with other people or in closed buildings is an infringement on the personal rights, and they have the right not to wear it. So the balance between your personal human right and your social responsibility, because you can go out among other people and infect other people, so you infringe on other people's human rights. So where is the balance, right? Which very much comes to the discussion or the question that Thomas Pfanne put. And then the second part is, Graham reminded us of this concept of building back better. So yes, we have this huge crisis, also mental health related, with a strong mental health component. A lot of governments understand now that mental health actually deserves to be a priority area in which one needs to invest. What are the chances you think that we will actually make that step forward, or are we going to build back, not better, but build back maybe even worse? So maybe Dovile, you can start.
Very complicated questions. But I think it's always the human rights are built on the premise that your right is ending where the right of others are concerned. So I guess it's the main kind of borderline between your right and your autonomy or your respect for other rights. But I would still would like go backwards and say that even before COVID, and now the COVID only disposed what we actually see as no human rights for some populations. So I guess the COVID also shown that actually people and in Lithuania we were very much working with anti-poverty network and network of other NGOs that actually very much stressed the need for vulnerable population and the people and population that are in the more risk than others for the vulnerable situations to actually to show that COVID showed the situation that those people and those population, they were not at all secured with their human rights. But I'm just now, trying to come with a very broad understanding what human rights are for people who are living in the poverty and who are not accessing any support or services and are left alone in even the high-income societies, as for instance, we are considered in Lithuania. So I think this very much showed also that people are suffering from human rights violations every day. And if we speak about, securing those rights, we first of all have to also think about not only restoring economy, but restoring the social justice and social and the social education, healthcare system that actually are in the key and core for securing and well-being of people of the main population and all the population people. So I guess this is now what I want to say, and maybe I can add something later.
Robertus.
You ask very difficult questions. In the end, well, how I see that is that if we look into mental health area, there are many people whose rights are violated before virus came to this world. So for people with serious mental illness and who are in those institutions, so this created much worse situation. So what concerns the society in general about their rights, I mean, if we do not speak specifically about people with mental health problems, so I probably wouldn't even have a clear opinion about that, because it's very. It seems that there is no clear answer to the how to deal with this on the societal level, because there will be always people who will be opposing or to those restrictions, who will be deliberately will not use masks and other things, so they become kind of dangerous. But so probably society has to have some tools how to deal with such people. Well, the restrictive methods are used in most societies. I mean, if we were like comparing China versus Western countries and so on, but let's think about different Western countries or that are using so much force against different groups of people, and that is happening not now, nothing special about pandemic, but in usual there are societies that are using so much force. And we know countries where there are huge demonstrations against the police officers who are abusing their power. But we are moving now further from mental health. So with what concerns mental health questions, so it seems that people who are having mental health problems, they are in much worse situation during these times, and how to go out of that. But it's again not only about people with mental health problems. People with different health problems are also having much much worse access to health services. So it's like it seems. Different health people with different health problems are not having enough services. So I'm just reflecting loudly, but I'm not sure if I'm answering questions that you posed.
Oh, yes, I think you're answering the questions. The question is, where do you see the balance? Between the personal space and the societal space, right? What is the moment? If you take the example of Wuhan, which Thomas Pfanner mentioned, where they eventually even installed cameras inside your apartment in order to make sure that you stay in your apartment. You have the example from the Netherlands, where the Prime Minister is all the time saying, well, people need to take their responsibility, whereas it's clear they're not taking the responsibility. So, when can a government step in?
So maybe now my colleague on the right would like to say something. I don't know where is the line. I don't know where is the line. I understand that there are so many cases when government is intervening and violating rights, and it's happening not during the pandemic. Mm-hmm. So the question is, shall we, because of the pandemic, can we move even further and violate even more rights of people? So I don't know if that's the direction that we need to go.
Danius, do you have the answer?
Yes, of course. This virus is very provocative, and hopefully will bring some sobering ideas to humanity, to humankind, because what was happening before virus, two best achievements of modern mankind were under attack, under increasing attack. Human rights-based approach with the changes of Trump in American administration, so US joined Russia, China, and other usual suspects to attack universal human rights principles, which are the best what was created. And this is why, what I mentioned in my presentation, some so-called traditional family values, this is not innocent concept. This is concept created by Russia and China. And you can trace these resolutions for last 12 years. And our patriotic forces are using this concept now, especially before election. So human rights-based approach was under attack, and evidence-based approach was under attack, because we had a lot of conspiracy theories, not only anti-vaxxers, a lot of conspiracy theories also attacking human rights. So with virus coming, initially it was seeming that democracy is losing. You know, Italy, Spain, terrible. China is a winner. No. Now, if you look around, the strong men are not so happy with the virus. They are losing, actually. So democracy has a chance now, and the human rights-based approach has a chance with restrictions. There are Syracuse principles where everything is described. The problem, I mean which rights could be cancelled because of public health crisis. It is described in Syracuse principles. The problem is that who will decide, who will be the experts, and who will control the experts. And are experts independent, or are they under Ministry of Health, for example, of government? And who will decide if measures are proportionate or disproportionate, and if measures are discriminatory or not discriminatory? So this is the biggest question, because so far this knowledge about this virus is the same exact science, this is my irony, as psychiatry. Psychiatry wants to be exact science, and it is not. And then you can manipulate with, you know, when you close people because of risk of suicide, risk of homicide. Something similar happens with virus, and of course there are two extremes, as always. You can overreact, and you can, as what Graham was warning, you can go to other side too much. For me, very interesting debate is, which is going on also in Lithuanian space, is when somebody tells, why don't we go some Nordic way? Not necessarily Swedish way, but Nordic. And the answer is, well, we are not Nordic, our mentality is different, our people are totalitarian, they follow only instructions. And Nordic, they are, you know, you can just advise them and they will follow. So my question is, does our government want us to go Nordic mentality, or our government is afraid that we can go Nordic mentality and start to think critically? So this is for me the question, when there is some attempts to tell, don't be like Nordic, it's better to be like China.
And what about building back better? You think there is a chance?
With mental health?
With mental health.
Yes, again, it is some, maybe I stay on my position, which I shared during presentation. I agree with most of what was told by presenters, including Graham. Except again, each country takes from international experts selectively what they like. So Lithuania took very passionately at modern psychotropic medications and not other suggestions. Where are the services in the community which are recommended by WHO, like psychosocial rehabilitation, outreach, they do not exist, because this is, we don't need it. And what I told, this is why we have full social care homes. So everything is in our hands. We can use this crisis to modernize mental health services, but there is no political will and no critical mass to do something differently. During such crisis, it's very good time for creative innovations. Our government is allergic to creative innovations. They borrowed all these billions and they are giving this to state-funded centers. And if you tell, what about private initiative, NGOs, privately working psychotherapists, why not to cover psychotherapy? Oh, no. We become then like Bolsheviks, We can give money only to our institutions, and all the others are not enemies, but, they could go to Soros and ask for Soros, The state has nothing to do with them. So this is some relic from communist past. If you are not funded by the state, you are out of game when it comes to support of mental health initiatives. So NGOs feel this very, very painfully.
So Lithuania-wise, you are not very optimistic, I see, worldwide, globally?
No, I mean, I am optimistic. Just if we agree on diagnosis, we can move forward. So far, there was no political will to tell that not everything is okay with mental health system. The official declaration that we're best in Europe because we have more than 100 outpatient centers. So this is absolutely uncritical, And this brings some worries. How can you really think that you are best in Europe, with such indicators of suicide and so on? Globally, it's impossible to predict, make prognosis, but the most interesting debate I like, we're very, very refreshing, is where reforms are easier to do, in developing world or in developed world. Some experts tell that in developing world it is easier because there is a room, there is a space. Most difficult to do reform in advanced country because they have so powerful psychiatry that psychiatry will not allow changes, because this is about change in power asymmetries. Yes, psychiatry should agree to lose some power to be better. And I think it's against human spirits to lose power. If you have power, you never want to lose it. I think this is the main problem, this asymmetry of power. Otherwise, there is a good opportunity now globally to at least to try to change, not that to lose biomedical model, but to add to it more support, different innovations like all these benches, in Africa and so on. A lot of innovations. I see future of this field as a very creative, creative way, and not hierarchical systems that only some experts know everything and others, it does not work.
Okay, then one last question to all three of you. When I speak to people, basically everybody who is not only in the mental health field, but in general, when you talk about the effect of this pandemic, now 6 months or more than 6 months, virtually everybody tells me that this has changed something fundamentally in life. What has changed for you, Dovile?
For me personally? For me personally?
Yes.
I liked very much also the Charlene's kind of reflections on being more or having more time for consideration for work, but a different kind of work, for productivity, although I actually noticed that I'm not as productive being at home as in the office. But what I think also very much struck me is that following the European, all those policies and the European kind of tendencies in the after COVID or during the COVID and disability issues, I would say that first of all, we need to speak to the stakeholders themselves, first of all. And really, and what we tried also in Lithuania is to, as much as possible, to try to monitor the situation, how people with disabilities are living in day-to-day lives, and in disabilities. What we also experienced is that NGOs, or as Daniel said, some more creative or innovative methods are much more easily introduced by NGOs, and during this crisis situation, that actually system is not following, or not even possible to follow those changing conditions. And this showed that actually, you know, we need to discuss some more creativity, some more alternatives in following the social needs of each of us. So I guess this was the main understanding for me, that it is really, it's only us who can actually say what we need, and then how we need to follow those needs.
So what is the question? What changed for me?
Yes.
One thing, I think what changed, or what happened to my children, so they got opportunity to see their father much more. So myself, I got more opportunity to see how my children are learning and participate in that distance learning process. As a teacher at the university, I was worrying how those classes and everything will take place, and it went very smoothly. So despite, let's say, despite the anxiety and all these worries, this situation also brought new possibilities to learn something. And it appears that many meetings can take place virtually, and also be very productive, and so on. So yeah, things are. So I look into this, what is happening. That yeah, it creates additional difficulties for some people, but also it creates something, provides some opportunities to learn something new. Yes.
Thank you. Danius.
Public health crisis coincided with changes in my life, because I was approaching the end of my mandate, and I was very seriously preparing, because I knew that it will be hangover, you know, and all 6 years I was reminding to myself, but all this attention is not because of you, but because of your head, and this will disappear immediately on 1st of August 2020. So I was preparing myself, because it's not easy. It's not real power, but sometimes you are forced to be escorted for 2 weeks in some very special countries. And this is a real test, because it's very, people get used very often to such things, and I was trying to monitor myself. So when it was over, and it was coincidence that travels stopped before end of my mandate, And I'm dreaming that I go to airport and then something is wrong and I cannot fly. And I'm not happy that that you cannot travel anymore. I hope it will change one day. But I think I have adapted already to new position. It is much easier, of course, to be like prophet on the hill and sending messages. They are right messages. Still, I don't withdraw them, but it's much more difficult to go to local situation and to try to implement them. I understand this. But still, these prophets are needed, I think, and I was happy to. I prophet because it's very, very funny position, Why shall we follow him? Because he's special reporter. What he told is truth. So I was using this quite effectively, but I know that to implement regionally, nationally, this is much more difficult task, and of course. We shall see how possible, what is possible and what is not.
Okay, so at the end, I would like to show you one clip which connects exactly to the last words of Danius, which is the second clip that we made in Ukraine. If I can find my folder, yeah.
Во всем мире существуют психические болезни, и каждая генерация людей имеет это биологически детерминированное зло. Но человечество каким-то образом пытается в 20-21 веке реабилитировать этих пациентов и помочь им приспособиться, несмотря на болезнь, к жизни. Для этого в цивилизованных странах существуют альтернативные заведения. Мы, советские страны, вышли из Советского Союза с тяжелым наследством. Мы имеем очень примитивную систему. Больница, интернат. Ну и немножко еще амбулаторная система при больницах. На самом деле, самые страшные условия всегда и сегодня в интернатах. Это места, где люди, не совершившие никаких преступлений, имеющие только особенности медицинские и социальные, они дезадаптированы в основном, их не хотят в обществе. Семьи, как правило, либо умирают, либо отказываются от них. Если говорить прямо, это без вины виноватые у них пожизненное заключение. Сейчас, во время карантина, эти люди страдают больше, чем мы, психически здоровые, потому что они нуждаются в каком-то общении, им труднее понять и осознать то, что происходит вокруг. Здесь есть страшная особенность, состоящая в том, что если раньше психиатрические пациенты, которые находились в интернатах, в основном на пожизненном пребывании, сейчас не имеют возможности вообще выходить оттуда. Им тяжелее, чем всем нам. А должно быть совсем иначе. Должны быть какие-то общежития для них, которые есть.
Somehow I'm sorry, the last part somehow fills, which is a pity. The clips will be later put on Facebook and will be available. So with this part, I would like to come to the end of the conference. Thank you very much for your presence here. Also, thank you very much for watching us on live stream. The recording of this conference will be put on the website of the Andrei Sakharov Research Center, maybe of the university as well. I would like to invite those who are here now to join us at the reception, which is across the square in the Adamkus library. Food will be served. And after that, for those who registered, there is a concert in memory of Leonidą Donskį at the Čiurlionis Gallery. We are fully booked, but maybe there is a possibility, because there are always people who do not turn up, that we will be able to fit you in. But we have our restrictions and we can have only a limited number of people there. So please join us for food, and I hope to see you next year at the next Leonidą Donskį conference. Thank you.